Our next session is a keynote address by historian, broadcaster and filmmaker Professor David Olusoga. To introduce David, please welcome Habib Naqvi, Director of the NHS Race and Health Observatory.
Welcome everyone to what is an exciting session today. Exciting because it's going to be both challenging and thought-provoking. The history of the NHS is intertwined with immigration. That certainly was the case in 1948 with the inception of our healthcare system, and certainly is the case today, 74 years later. The fact is that the story is not always a positive one. As a son of an immigrant myself, I'm aware of the struggles my father went through in the 1960s in terms of his own career in pharmacy. And so that relationship brings up many questions for us. What do the experiences of people who have come to this country to work in the NHS and subsequent generations tell us about our healthcare service and about society as a whole? And of course, the immediate challenges of today. What lessons should we be learning from the disproportionate impact of COVID-19 on our diverse communities and healthcare staff? Who better to answer such questions than David Olusoga? David is a British-Nigerian broadcaster, filmmaker, and historian. His most recent TV series include Empire, Black British: A Forgotten History, The World's War, 3 seasons of A House Through Time, and the BAFTA-winning Britain's Forgotten Slave Owners. As you will know, many of these have been award-winning books. David was also a contributor to the Oxford Companion to Black British History. He writes for the BBC History magazine, for The Observer, and for The Guardian. He's also a presenter on the BBC's landmark arts series, Civilizations. And of course, who can forget, in 2020, David held an exclusive interview with the former President of the United States, Barack Obama. Please welcome our good friend, the excellent David Olusoga.
Well, thank you so much for that kind introduction. Thank you so much for inviting me here to speak. I'm biased, obviously, because I'm an historian, but I do think we need to entwine history into everything that we do. When we think about where we are today, we have to remember that we are at the culmination of an historical process. And there are 2 aspects of life in the UK and history in the UK that are intertwined in ways that I think we never really fully have acknowledged. The first is the history and the present-day reality of the National Health Service. I don't need to tell you, the nation's most beloved institution, and never more loved than it is today after the pandemic, although using the past tense when speaking about COVID-19 feels a bit dangerously premature. The second is immigration, perhaps the most single toxic issue in political debate over the past 70 years. Our passion for the NHS as both an idea and as an institution stands in stark contrast to our constant, bitter, divided and often distorted debate about immigration. And I say this in the week when the first flight of asylum seekers to Rwanda has, as you know, been prevented from taking off only through a last-minute legal intervention. I'm a historian of empire, among other things, which means one of my focuses is immigration and race, which in turn means inevitably and unavoidably that I'm interested in the history of the National Health Service. The story of immigration from the former empire and the story of the National Health Service are, as I say, intertwined to the extent that they cannot be seen as separate histories. Indeed, the NHS and the Windrush, the symbolic arrival that marks the beginning of post-war Commonwealth immigration, are, historically speaking, twins. It was on the 5th of July, 1948, that the NHS opened its doors to the nation. just 12 days after the Windrush had landed at Tilbury Docks. The 492 men and women from the Caribbean came ashore to start building new lives in the UK. The passion that the British people felt for the NHS was there from that summer in 1948, the summer of the inception of the National Health Service. And even by then, phrases from the Beveridge Report and from the political speeches of the 1940s were part of the atmosphere. They had become subsumed into the language. The phrase "from cradle to grave," which comes not from the Beveridge Report, but from a radio broadcast made by Churchill in 1943, is as famous as any phrase from any of Churchill's great speeches of 1940 after Dunkirk or during the Battle of Britain. Within just a month of the 5th of July 1948, 97% of the British population had applied for their NHS cards, the documents that allowed them to access the new health service. And within those same first months, the NHS was thrust into the very first of the many crises that have, as you know, punctuated its history. In 1948, the NHS took over the old system of voluntary hospitals, the existing local hospitals, the charitable maternity wards and the TB hospitals, along with the rest of a complex and creaking network of inadequate health provision that the new service had been created to augment and replace. In England and Wales alone, 2,688 hospitals were brought into the NHS almost overnight. And the NHS also took over caring for a UK population whose immediate healthcare needs were amplified and exaggerated by decades of neglect and gnawing poverty that had forced huge numbers of people to simply tolerate ill health, chronic conditions, or treatable disability. As a result of this legacy of neglect and poverty, along with other factors, the NHS from the start cost more than had been anticipated. Management costs increased, as did the costs of improving and maintaining those thousands of hospital buildings, many of which were in a poor condition from the start. But the biggest problem was always a shortage of medical staff, as it was to be in many of the crises that were to follow, including arguably the current crisis facing the NHS. The NHS had been created, the nation had rushed to register, and now there were not enough staff, in particular nurses, to meet the growing demand. Not only was there a lack of nurses, there was a lack of people willing to train to be nurses. The same was true for other positions. The post-war economy was, overall, in need of 1.3 million additional workers, and thus the job market of the late 1940s was a seller's market. And many single women, some of whom had been liberated from domestic work by working in industry during the war years, were seeking to plan careers and choose jobs that they wanted to do. Many others had put off having children during the war years, and there was, of course, still the strong societal belief that men should work and women should be home workers. Thus, in 1948, at the start of the NHS, there were 54,000 nursing vacancies. What helped fill this void was the factor that was always to underpin and support the NHS: immigration. The NHS, as we know it, was made possible by migrants from the outset. Indeed, it might not have been able to truly become a national service and meet the enormous expectations placed upon it without them. In 1949, just a year into the health service, the Ministry of Health joined forces with the Ministry of Labour and the Colonial Office, who reached out to the General Nursing Council and the Royal College of Nurses to begin to place adverts in the nursing press asking for women from the colonies who were interested in coming to Britain to apply to work as auxiliaries and trainee nurses. As well as nurses, auxiliary staff and domestic workers were also recruited. The advertisements featured interviews with nurses already in the UK who confirmed that across the country there were jobs that could be found. Recruitment campaigns were extensively and energetically supported by senior nurses and senior NHS staff who went to the colonies for this purpose. In 16 British colonies, local selection committees were established, while vacancies in the NHS were also advertised in the local newspapers in the colonies themselves. The trainee nurses, auxiliary staff, and domestic workers who heeded this call were young women and men drawn from all over the world, but many came from the Caribbean islands as well as Malaya and Mauritius. Many others, of course, came from the Indian subcontinent and from Ireland. And from 1955 onwards, the government set up schemes to assist people coming to work in the NHS with the cost of travel to the UK, although many others funded their own journeys. And many of these overseas nurses were quickly conscripted into what were regarded as the Cinderella specialisms, the TB wards, the psychiatric hospitals, looking after some of the most vulnerable patients. Over the coming decades, British colonies became former colonies, and yet they continued to send a constant flow of cheap but well-educated labour that was fundamental to addressing the NHS's ongoing recruitment crises. By 1965, there were 5,000 women from Jamaica alone working in British hospitals. By 1977, 12% of all student nurses and midwives in Britain were recruited overseas. 66% came from the Caribbean. Between 1948 and 1973, 100,000 nurses arrived from the Indian subcontinent, the West Indies and Africa. And during the same decade, there was, of course, extensive recruitment of doctors from India. In 1960, almost 40% of junior doctors working in the NHS had come to Britain, either permanently or temporarily, from the Indian subcontinent, India, Pakistan, Bangladesh, Sri Lanka. And some of these Indian doctors who were working in the NHS were not veterans of the Windrush generation and the waves of post-war migration, but veterans of earlier stages in the British history of migration. One estimate suggests that in 1945, 3 years before the establishment of the NHS, there were already around 1,000 Asian doctors working in Britain, most of them in general practice. And by 1971, even after expansion of medical training in the UK, 31% of all NHS doctors in England were foreign-born. And this is not just about the Caribbean and India. In 1971, 12% of UK nurses were Irish. Ireland was always central to this story. And at the start of this century, in the Rhondda Valleys of Wales, 73% of doctors were South Asian. Currently, almost one-third of NHS doctors are from abroad. As we well know, and has been well documented, many of those who came to build the NHS in those decades endured verbal and even physical abuse. They encountered racism and discrimination, not just on the streets of the communities that they served, but within the wards and the corridors of NHS hospitals. A Home Office memo from 1949 framed this racial abuse as an issue that should be addressed, not with training, not with anti-racism education or a zero-tolerance policy, but by setting limits on the numbers of non-white NHFs in any particular service. The memo stated that, quote, "It has been found that the susceptibilities of patients tend to set an upper limit on the proportion of coloured workers who could be employed either as nurses or as domiciliaries." It is the story of the NHS in those early decades that I, as an historian and a documentary maker, have been most interested in. And learning this history, and more importantly, encountering people who were part of it has been a profound experience. 2 years ago, I was honoured to meet and to interview remarkable people like the late Kailash Chand, OBE, a man who came to Britain, not as the tabloids would constantly suggest, to use the NHS, but to build the NHS. As a trainee doctor, he heard of the health service and the principle of it being free at the point of delivery and the point of need, and came to Britain specifically to be part of such a service that worked under such principles. And in that he was not unique. Part of what has always drawn migrants to work in the NHS is their belief in those core principles. While the NHS is, of course, a national health service, there is international belief in its mission and international admiration for it, and we underestimate that at our peril. Yet these two phenomena, the National Health Service and immigration, have, as I said, from the beginning been two sides of the same coin. That history of immigration and the NHS has been one of political doublethink, a history of governments saying one thing for political effect, but doing another. Because even as Enoch Powell was warning of rivers of blood, or Margaret Thatcher was warning of a country being, quote, swamped by immigrants, and even as the hostile environment was being rolled out, Britain was not only welcoming doctors and nurses from Asia, Africa, and the Caribbean, the Philippines, and elsewhere, it was actively recruiting them. And that doublethink runs even deeper, as throughout its history, migrants have worked to build up the NHS while at the same time have been routinely accused of putting pressure on the service. Debates around immigration have time and again focused on the belief that migrants coming to Britain were, quote, health tourists, seeking access to NHS services. Immigrants have been deployed by governments as the salvation of the NHS while being presented simultaneously by the tabloids as one of the greatest threats facing it. This despite the fact that use of health service by migrants may well be lower than that of the UK-born population, in part, perhaps, because migrants on average tend to be younger. In 2020, this twin history of migration and the NHS, a history inflected with issues about race and discrimination, entered a new chapter in the most dramatic and the most tragic of ways. When the pandemic, when COVID-19 revealed to the British public, in ways that I think were unimaginable before 2020, just how much our most beloved national institution relies on migrants and the descendants of migrants. Because the pandemic also, in the same years, revealed that those same communities were the most vulnerable for socio and economic reasons, and because of racism and discrimination. As you will know better than I, Black and brown NHS staff suffered higher infection and death rates during the pandemic, mirroring in many cases what was happening within the communities they were drawn from. All 10 of the first NHS doctors to die during the pandemic were from minority backgrounds. According to one metric, although they make up 20% of the workforce, they made up 60% of those who died in the pandemic. In multiple ways, the effect of the pandemic within the NHS and within our society more widely has been to illuminate the ways in which race and disadvantage and discrimination operate. Health disparities between communities have never been more manifest and well documented, in part thanks to Habib and his team. What has been remarkable at this moment is the way in which political leadership has been left behind. Making programs about the history of race and discrimination in the NHS comes with an inherent risk, which is that it is possible, accidentally, unintentionally, to imply that such forces, such discrimination, is a historic rather than a contemporary reality, that such forces are no longer a factor within the health service of today. Not only are racism and discrimination still disfiguring the health service and damaging the lives and opportunities of minority staff and users of the NHS, such discrimination represents an active and present risk to the health of the health service. The NHS Race and Health Observatory report of earlier this year that deployed research by the University of Manchester, the University of Sheffield and Sussex, and cited 178 studies, presented evidence that, quote, ethnic inequalities in health outcomes are evident at every stage throughout life, from birth to death. The pre-existing evidence of health inequalities that the author of the report noted had failed to lead to what they described as significant change. That report also concluded that the health of ethnic minority people in the UK is affected by, among other factors, quote, discriminatory treatment from healthcare staff. And as a result of such experiences, some minority communities delay, quote, seeking help for health problems due to a fear of racist treatment. And this week's review by the BMA, published yesterday on the opening day of this conference, reveals in the starkest of terms how minority healthcare staff themselves are also suffering from discriminatory treatment. You will know, and you will have discussed the report exhaustively yesterday. But medics reporting experience of racism while doing their job, leading to a deterioration in their mental health. 42% of black, 41% of Asian doctors having considered leaving or having left work in the past 2 years. 60% of Asian, 57% of black medics reporting racism as standing as a barrier to their career progression. and a reluctance among healthcare workers to report incidents of discrimination for fear of damaging their careers, or simply because they don't think they'll believe or their complaints taken seriously. This has to be described as systemic failure, and therefore what is needed to confront it is a recognition of the broader systemic nature of racism. Yet rather than acknowledge how racism and discrimination are impacting the NHS and our society more broadly, politicians seek culture war headlines, using official reports to muddy the waters and even discredit the notion of structural racism itself. These culture war strategies are not the activities of a political class that comprehends the corrosive impact of discrimination on communities or the NHS. It is not the actions of people who understand that these are the communities in which the NHS has always relied on, or politicians that understand that race and immigration are factors without which we can't understand the past or the present of the NHS. Today, after 2 years of pandemic, and perhaps more than at any time in its history, the NHS is publicly and overtly loved and praised. Yet over the same time, never have its failings towards both patients and healthcare been better understood when it comes to these issues of race and discrimination. And our deep, passionate respect for the NHS should not blind us to the fact that on these matters it is in need of reform. They should not inhibit us from recognising that the National Health Service, like many other British institutions, perhaps most British institutions, have profound issues around race, diversity, discrimination and inclusion. Because although the NHS is special, its failings are not unique, but they are perhaps less understandable, given how much the communities that face discrimination have contributed to the NHS over 7 decades. Because the NHS matters so extraordinarily much in our society, its failings, unfair though this may be, matter more. Our love for the NHS cannot, as I've written, be unconditional, because to respect the service would be to truly respect all of those who contribute to it. Those who over 3 generations, the first nurses from the Caribbean, the first doctors from India in the late 40s, right up to the people who make it work today, have faced and are facing racial discrimination and abuse. We cannot allow our passion and love for the NHS to blind us to these realities. Thank you very much.
And now it's an opportunity for you, both on Slido, the people viewing online, but also the audience, to ask David questions. We have 2 standing microphones, 1 and 2. If you've got a question, please please head over to those mics. But I'll start with a question myself. David, thank you so much for an elaborate, a very focused speech, highlighting the contextual issues that we have today. First question, I guess, is last year the Commission on Race and Ethnic Disparities, the CRED report, was criticised for downplaying the role of race-based factors in terms of discrimination. How does the reluctance to fully acknowledge racism impact on narrowing the inequality gaps that we see in society?
Thank you. I think when people look back at the history of that report, it will be noted as one of the most remarkable demolitions of an official government report that there's ever been. I can't think of an official report that has been so discredited by the experts in every field that it ventured into. Educationalists, employment experts, health experts. One by one went through that report. They not only questioned its findings, in some cases they challenged how it was possible to reach those conclusions from the evidence that was drawn. Some pointed to a selective use of evidence. Now, to be fair to the authors of that report, the press release that I think was out of their control, that was released before the actual report, distorted some of their findings. And I think a number of people involved in that have pointed that out, and I think it's fair to them to say that. But the summary that was produced, that was written by Tony Sewell, is something which I think is rightly criticised. I think it exaggerated the findings. I think it misrepresented some of the findings. There's two parts to that report. There's the recommendations, many of which I think are very good, and then there's the report itself. There was a review of a book once by Samuel Johnson. It's probably the most cutting reviews of all time. I can't remember the name of the author, but he said to this author, he wrote a newspaper about this author, that his book was both good and original, but the parts that were good were never original, and the parts that were original were never good. And I think you could say the same thing about the CRED report. The parts that were good were the recommendations taken from the Sewell report, taken from other reports, and the parts that were original were, I think, have been demolished by sector after sector. So I think we mustn't give that report too much credence, because I think it has suffered such, it's been mauled so profoundly by experts. But I think what it does speak to is the positioning by politicians of these debates as a false binary, that we have to choose as a society between race and class. And I think that false binary that many debates are channeled down is extraordinarily dangerous. I think that this sidelining of racial issues, just in a practical sense, I think makes no sense, but it also makes no sense, and it's also disingenuous, because of course race and class intersect in all sorts of complicated ways.
Yeah, absolutely, and that intersectionality is absolutely important. Please do go to the microphones. There are 4 now, in fact, situated in the auditorium. If you've got a question, I'll go to number 4 at the back first.
Hello, can you hear me? My name's Dr. Natalie Darko. I'm Associate Professor at the University of Leicester. I just had a question for you, David, about the importance of migration history. Your work and lots of others has demonstrated the impact of migration history on health inequalities and different conditions. Do you think the NHS needs to do more to capture and evidence or record, particularly in ethnicity coding data, migration history? Do you think that would be beneficial?
Thank you very much. I'm also a graduate of the University of Leicester, so good to hear from you. I'm not a clinician, so I need to be careful about the areas that I wander into. But it seems to me that the more we know about migration history in all sorts of areas, the better we can respond to the needs of communities. I think the most stark example of how ignorance of migration histories, and also the deeper histories of empire that underpin it, can actively cause genuine damage to our fellow citizens, undermine our society, has got to be the Windrush scandal. The lessons learned review, led by Wendy Williams, into the Windrush scandal, it's complicated and fulsome reports, but as an historian, the bit that stands out is their conclusion that one of the precursor factors that created the atmosphere within the Home Office that enabled that scandal to happen was ignorance of the history of immigration, of British imperial history, and of the history of the immigration laws passed from 1948 onwards. To the extent that people who were making decisions about the lives and the status and the nationality of the people in front of them didn't understand where they came from. They didn't understand the historical journeys that were their personal family journeys. If you don't understand that history, if you don't understand the connection between Britain and Jamaica, or Britain and India, or Britain and Barbados, the idea that you can understand and you can make official judgments about people's relationship to Britain, I think is demonstrably shown to be, if not impossible, but made more complicated. Because immigration is such a toxic political issue, there is a marginalization of the study of it. I mean, one of the things I point out whenever I talk about these issues is this is not an area where I do original archival research. This is an area where I use my position as a public historian to talk about work that has long been there. Kathleen Paul and Wendy Webster, two fantastic historians who've been examining these histories for decades, and yet they're not known. Their work isn't known. Their books aren't reviewed in national newspapers, and yet their work is absolutely critical. So the marginalising the history of migration, which I think is a part of marginalising the history of empire, means that we are not equipped to understand these backstories of communities. And if we don't understand who people are historically, if we don't understand their journeys that brought them to Britain, I think in all sorts of ways, we can't get to know them properly. So I think we're a country that's unwilling to discuss immigration because we see it as a political issue rather than a fundamental and integral part of our history and our society. Thank you.
Number one.
Thank you. So I'm Julie Hankin. I'm Medical Director of a mental health trust in Cambridge and Peterborough. Thank you. That was really powerful. And it was really striking that the talk before you on the stage was about selling a quest for a single version of the truth through data. And I wondered if, as a historian, you had a view on, is this belief we have in the NHS that a single version of the truth is either possible or good part of what goes wrong in these conversations? We don't have those multiple voices.
Thank you. I think historians are allergic to the idea of a single version of the truth. Our job is to complicate things, be awkward. When I was younger, I was saying this on stage the other day, when I was a young historian, I thought our job was to prevent society making the same mistakes as in the past. And that wasn't, now in retrospect, a childishly optimistic view. Our job is to make things more complicated. Our job is to stop people taking this armory of details from the past and using them for political or perverse purposes. And we do that by complicating, by showing that there is multiple truths, that there's multiple ways of understanding things, that societies are much more complicated than we often think. And I think there is a danger when it comes to the NHS, a very specific danger, that our pride overwhelms our critical faculties. I wrote a piece about Habib's work in the Guardian earlier this year, and I had to, in that, say how awkward I found it criticising the NHS, because there is a political tradition, which is almost as old as the NHS, of attacking it for political purposes, and to criticise it feels wrong, except for we know that if you truly care about something, if you truly care about a person, you're honest with them. And we need to have that, find that capacity to have that complexity, that dual voice, that double truths, that we can love the NHS and point out its failings. And speaking to people who have been nurses who came to Britain in the 50s and 60s, doctors who arrived and had to fight for any sort of progression in the same decades, speaking to them, even when they're talking about their own painful experiences, they are capable of that duality. They still love the NHS, even when people like myself interview them and they reveal to us shocking experiences of discrimination and sometimes abuse. So if people who are the victims of that negative history can still invest personally and passionately in this unique set of beautiful, I mean, it's a word we rarely use, they're beautiful principles behind the NHS, then the rest of us, I think, can find the capacity to do the same. So I'm inspired, as I was when I've been making programs about this, by the people who, despite their experiences, still invest personally in these ideals.
Thank you.
And David, in your opinion piece earlier this year in February to the work that we produced, you wrote that our love for the NHS cannot be unconditional. There's a question here on Slido which relates to that in terms of what can we do to reform the NHS. And very often the question says, it seems as though we're preaching to the choir about racism. How do we get those who aren't listening or paying attention to these issues to focus on reform and to shift the dial in terms of race and racism?
Well, I think the NHS's issue with race, to me, reminds me of a lot of other liberal sectors. The university sector has, I'm afraid, a terrible record of failure on inclusion, outreach, diversity, and I'm struggling to see the level of intervention and seriousness on those issues that I would like to see within the university sector. Another sector I work in television. There has been, as long as I've been in television, there have been year after year of initiative after initiative that have all resulted in the same outcome, failure, either complete or partial. So this pattern, this problem that the NHS is facing is not unique, but as I said, what I think is unique about the NHS is how much it matters. So it would be unfair to say the NHS has a unique and off the register issue with race. It's just that it matters more because it's health outcomes. because it's people's lives at play. Now, I want reform in all of those sectors, but the NHS mustn't be immune from this just because it matters so much to us. But I think we need to learn. The police service, particularly in London, is struggling, I think, in ways that are very comparable. And I think it's an interesting comparison looking at the Metropolitan Police's struggle with this idea of institutional racism. Seems to me very similar to the NHS. So I guess what I'm saying is we mustn't put the NHS in a separate category because it is so important and so loved, and not realize that it can be special, but its problems can be actually anything but special. They're quite typical, its problems. And I think when you have powerful institutions with a strong sense of themselves, there is an inbuilt defensiveness. And that defensiveness becomes even more powerful when people outside the service feel inhibited from criticizing it because of our affection for it. We can't allow the NHS to fall behind even further on these issues of race and diversity out of well-meaning optimism for it.
Absolutely. Number 2.
Thanks, Habib. I feel like I'm in church, like I want to say hallelujah every time you say something. My name's Patricia Miller, David. I'm the Chief Executive of the Integrated Care System in Dorset. And previous to that, I was a Chief Executive of an NHS hospital, one of only 9 from an ethnic minority out of 230. I am now the single ethnic minority Chief Executive for Integrated Care Systems out of 42. So I'm a very lonely person. But my father and his mother and 2 sisters came here as the end of the Windrush generation in 1965. And my grandmother and my 2 sisters became nurses. And when I think about my family history and talking to them about their experiences of society in the NHS and my experiences over the last 30 years, I hear lots of colleagues saying things have changed, but I actually don't think things have changed very much. Racism is much less overt, but it's still pervasive in a much more subtle way. And my question to you is, given that it is a societal issue as you've described, do you think that our reluctance to teach real British history in its completeness in school and teach the reality of colonialism, no matter how uncomfortable it is one of the main reasons why we are struggling as a country to move forward in that context and really change for the better in terms of our societal culture?
Well, thank you so much for that question, and very sorry to hear that you're lonely. I hope you're not lonely for much longer. I think when you're not lonely, then the NHS will probably got somewhere. I think there's a very specific function that we put history to in this country, and it's to make ourselves feel good. Now, not all countries do that, though many do. If history exists to make us feel good, to tell us that we're a special, magical people with a unique history, always on the right side of history, then you have to airbrush out of it every phenomena, every story that doesn't operate to achieve that outcome. And that means you can't have the histories of immigration, you can't have the history of colonialism, of slavery, of the East India Company, of the violence and the racism that underpinned empire. You need to airbrush them out. And there's lots of problems with that. The first is that you get a not dishonest version of your history. The other problem is that those histories are the family histories of 14% of our population. Most minorities in this country trace their ancestry back to Commonwealth countries. And we have created a situation now where people will regard my history and the history of many people in this room not as part of their history, but as a threat to their history. And this is coming to a conclusion, because what's happened for reasons I don't understand and I haven't heard a convincing explanation for is a new generation of younger people have emerged, the most diverse generation there's ever been, and they don't see history as something that should make them feel good. They instinctively think history should be challenging and difficult, and they have a profoundly different relationship with history to their parents and their grandparents. And so what we have is what others have called the history wars. We're in this battle for what British history is. It's a battle being fought over curriculums, over what's published, about which statues stand, which should be in museums. It's a battle about what we should be proud of or what we should re-examine. And I think that it will be resolved, but I fear it'll be resolved by our children rather than us. I think this period is the battle, and our children will force these changes upon us. Because to have a history that only exists as a form of recreation means that we can't have a shared history. Because if my history makes you uncomfortable, if my history is regarded as a threat to your history, then you have to dismiss or marginalize or minimalize my history. And it creates this problem, is that we don't understand where we all came from. The journeys that brought us all together. We were on the banks of a river that was one of the centers of the slave trade, that after that was the center for importing cotton produced in the Mississippi Valley by 1.8 million African Americans, that was then shipped to the 4,500 mills of Lancashire. This history is all around us. Just opposite us were the shipyards where the merchants of this city built battleships to send to the Confederacy to defend slavery. And we pretend none of this happened. We pretend that this history somehow has had no impact upon us. There's a reckoning with British history that I think is going to be painful. I think is going to be, in the short term divisive, but I think it will be one of the engines that will push us towards a recognition of the fact that the legacy of that history is the discrimination, the disadvantage, and the unfair outcomes that we are living with. Because that history didn't just build warships and buildings and fortunes, it left behind the idea of race. And that's what we're fighting against. Thank you.
I'm going to go to number 1, please.
Thank you, Habib. Sorry. My name is Lena Uller. I'm chair at Derbyshire Healthcare Foundation Trust, and I'm also the patron and trustee of the Ahmed Iqbal Ullah Race Centre in Manchester.
Manchester, yeah.
So I think David has been meeting our team there.
I have.
Yeah. So my question is, this room is full of NHS people, NHS leaders, and we hear, I've been in the NHS for 30 years now, and I've seen the cycle of we must do something about race, we must do something about equalities, we must do this leadership initiative, and this is happening all the time. But the dial hasn't shifted, and Habib's work with the rest clearly shows there has been some change, but not enough over the years. So as a historian and as somebody who knows the NHS and has done quite a bit of work on this, what advice would you give to us, everyone in this room? What can we do? What can we take away and actually implement that will get some traction behind our good intentions around race? Because and at the moment, it still feels like good intentions. We have to move away from good intentions and actually get that change on the ground. So the leadership commitment is there, people sign up to it, but it doesn't filter down. And we know from our res data and staff surveys, what people tell us is that it isn't changing on the ground. So what can we, everybody in this room, take away today and go back to their workplace and do different that will have some impact?
What can we do, David?
Thank you.
I always fear that historians are in a very bad place to give advice. If you see a grouping of historians at a book launch or something and look at us rowing over tiny little details, we're somewhat too insular to give advice. I think what I would like to say is that we are on the cusp of such enormous demographic change that people who won't see, those who are resistant to doing these changes because they fear about their own vested interests, people who are resistant to these changes because they are willfully blind to the issues, people who just struggle with empathy. Some of them might listen to the simple demographic realities. If you want to see the future of this country, go to an infant school in this city or Manchester or Birmingham or London and look at the backstories and the family histories of the children. That's where we're going. An infant school is flash forward 20 years into the future. The demographics of Britain are shifting enormously. And what I notice, and this is quite disturbing, the people who get this are commercial institutions because they're thinking about money. And they're thinking, who's going to be our clients? Who are going to be our customers? Who's going to work for us? Who's going to be our leaders? What's our succession planning? And if they look at their business plan and it does not speak to what in England and Wales, by one projection, would be 30% of the population by 2050, those children in school and those yet to be born, they see financial bottom line cash flow crises and they act. And it's institutions who are in some ways insulated from those economic realities who are dragging their feet. So you have this perverse situation where it's actually money-driven organizations, far more than the university sector, the NHS and others, who are alert to this. But those realities are the realities. 30% by one calculation, England and Wales is going to be diverse. And it's not just them, it's their extended families. And there's huge attitudinal shifts in generations. To ignore these things, these issues now, is, I would argue, suicidal. But we need not just companies and banks and commercial organizations to get this. We need our beloved institutions, our universities and the NHS above all, to understand this out of self-interest, if doing it for moral reasons is too much to ask.
Thank you, David. I'm very conscious of time. I'll take, if I may, just maybe 2 more questions. Number 2 and then number 4 at the back.
My name's Jo Myers. I'm Director and Trustee at the Florence Nightingale Foundation. I just want to thank you for your eloquent expression and address about history, because at school I got unclassified for history in O-levels, and if you were my history teacher, I'm sure I'd have got an A. You've made it sound... I had to learn about Hitler and Stalin and World War I and the flappers in America, and I still don't understand where the relevance is for me today. But the point I wanted to ask you is you mentioned that when racism was first spoken about, one of the politicians mentioned rather than dealing with anti-racism is to just send people back or limit the amount of people coming over from overseas. Fast forward to 2022, there's even more people coming over and we're relying so much more on immigration and international recruitment to maintain, to bolster and lift up the NHS. What are we going to do? Because we can't limit them because there's not enough people in the system to do the job. And we've got to such a critical point now. There's a film out called Exposed, which actually explains very vividly what is going on in the NHS with nurses. There's actually a third of doctors from ethnic minority backgrounds that are leaving the NHS because of the way they're being treated. So we are at crisis point, and I'd like to know from you, what can we do? Because as somebody mentioned earlier, it's each individual, we all have to be accountable for our own behaviours. We've changed the name of racism to microaggression and gaslighting, and we make it sound unconscious bias and all these nice, pretty words. But basically, it's bad behaviour, people treating people badly, and it's not really helping the patients or the staff or the NHS as a whole. What can we do? What must we do?
Thank you, Joan. And if we can take number 4 as well, if that's okay, David, and then we can tackle 2 at the same. Number 4 at the back.
Thank you, David and Habib. So I'm just picking up from the previous questions is that despite more awareness, many interventions and more initiatives, the dial hasn't shifted. Now, as you picked up the whole life cycle from hire to retire of the ethnic minority staff, if they manage to reach the retirement without being disciplined, without being sacked, is affected by. And I think one of the big thing is many of these factors start even before the hiring things in terms of the, starting from the educational attainment, from the university, access to apprenticeships and anything which kind of get to there. So does there need to be done more in collaboration of the community, the education systems and things hand in hand with what we're doing?
Great, thank you so much. There's 2 questions for you, David.
I'll be brief. I think we need to understand that immigration is not a toxin that's destroying our society. We're reaping the whirlwind of politicians and newspapers who have used
immigration to win votes and to create electoral triangulations. That's something which actually keeps our institutions and our economy alive, something without which we cannot operate, has been so demonized, even though it's at a much, much lower level than it is in, say, Germany or Turkey or other comparable countries. It is such a toxic issue that we have a political system that doesn't function. The fact that we're having a pantomime of a horror policy of deporting people to Rwanda, probably for culture war reasons rather than anything practical, shows how the weaponization of immigration is a political tool but a societal toxin. In terms of, one of the dangers is, and I see this in the university sector, I see this in television, is people blame the previous chain in the ecosystem for their failings. People will say, oh, it's people coming out of university with this disadvantage or that disadvantage. The problem is at school. Well, you're right, the problems are societal, but something cannot be our direct fault. We can say that there are problems we inherit from other parts of the ecosystem. Something cannot be our problem, our fault, but it's still our problem. And this passing the buck of where the problem initiates is something which I see in some of the sectors I work in. And I think it's profoundly dangerous. This is a societal issue, but it is also, it comes down to every institution and every cell within that institution to think about its policies, to think about its outcomes, and to think about the individuals under its care.
Thank you so much, David. Unfortunately, we've run out of time, but thank you for helping us to frame the historical context to some of the challenges that we have today on race and racism. Please give a very warm goodbye to David.
Thank you very much. Thank you. Thank you.
Thank you so much.
Thank you very much.
Our next session is the challenge of maintaining a focus on health equity as we manage the elective and diagnostic backlog. Please welcome to the stage our speakers and session chair James Mackey, National Director of Elective Recovery, NHS England.
Morning, everyone. So sorry we're slightly late. We've got a great panel today. So Kieran's going to kick us off with a presentation to open up the discussion, and then we'll hear different perspectives over about half an hour. And then we're going to try and give the opportunity both through Slido, which hopefully everybody knows to use, but also to take questions from the audience on this this important topic. I'll just try and kick it off with a few words from my point of view. So, first of all, in elective recovery, the NHS has made fantastic progress on the first difficult step, which is the long wait task, the 2-year task, where the published stats today show really significant reduction from where we were in the autumn and on track to be where we need to be at the end of June, beginning of July. But the next bits are really hard and complicated as always, so we're going to have to just really think through how do we kind of shake the game, change the game to get into this next phase. When we talk about the list, people always focus on surgery, but over 5 million of the patients waiting today, of the 6.5 million, won't go anywhere near a bed. All of their experience will be outpatient and diagnostics. So in terms of our focus, we've got to really think about that. And I think one of the really strong things of the last few years has been this concern about inequalities, and at least people talking about it, emerging evidence, some approaches being developed across the country, but also recognition that this is really complicated and messy. It's actually quite different in different parts of the country, so the approaches need to be slightly different as well and tailored to all of that. My personal view is we need to stop talking about this and start doing things. So really, in sort of framing the session, that's really where I think we want to get to in the Q&A if we can get to that point. So I'll stop there. Over to you, Kieran.
Great, thanks, Jim. So, thank you, Jim, and I'm just going to take you through how we've thought about coupling elective recovery to health inequalities. And I'm going to start with some facts, because I know COVID has really exposed pre-existing inequalities. It then made it worse, and I think there's a risk that things could get even worse. But the advantage of having the discussion now is actually, I think we're in a position where we can do something to mitigate that trend of making it worse. So I'll start with a few facts very quickly. We know that there is a socioeconomic gradient in health-seeking behaviour. So the more affluent you are, the less likely you are to attend urgent and emergency care, and the more likely you are to get your care through an elective care pathway. And of course, the opposite. Our more deprived patients actually attend A&E more, and they get less elective care. So there's a lot of evidence that exists. And of course, every city has its own map around the gap in life expectancy across the socioeconomic gradient. And in Coventry, we have that gap, which is about 10 years across the number 10 bus route, but every city will have that. And the third bit of evidence is that actually, if we don't do anything and we just restore services based upon waiting times alone, inequalities will get worse. And I'll explain briefly why that is the case. So those are the questions that we asked ourselves about April 2020 in Coventry and said, where do the inequalities start to emerge? Are they justified? And can we do anything about it as a healthcare system? Because we know that 10 to 15% of health inequalities can be influenced by health systems per se. And we were no different to anywhere else in the country. Our waiting lists were growing. We were trying to get as much elective care continuing safely as possible, but then we were challenged by the impact of COVID, and I don't need to labour what that is. But I guess what was really welcome was that inequalities featured as a priority when it came to restoring services, and there were 5 areas which I won't go into here that really led our thinking in how we couple restoration to inequalities prevention. So very briefly, we were very keen to have proactive case finding. So the 6 million Jim mentions, I think, is probably likely to be more than that if we proactively go out to find patients who deserve the care that they need. So we know that some patients haven't presented yet, and we can use joint strategic needs assessments to do that. The second is clinical prioritization, and I'll park that but dwell on it in a short moment. And the third was really embedding prevention strategies and active waiting and access to prevention across the entire pathway of care from the point of referral by GPs. Now, just to briefly explain why RTT alone fuels inequality, we know that William from Warwick is likely to be more affluent, fitter, healthier, and at the earliest possible point of hip pain will go to his GP, and he will hit the 18-week pathway much earlier in his disease process than a more deprived patient. But because he has less comorbidity, he's fitter, he has better health-seeking behavior, he'll fly through that 18-week pathway, get his operation, recover well, and be back home working at the desk within days of his operation. But compare and contrast that with Norman from Nuneaton. From a more deprived background, he has diabetes, hypertension, smokes by the age of 20, much more comorbidity because he's on a 0 hours contract. He can't afford to take time off work, so by the time he sees his GP, his hip is so degenerate that his surgery is more complicated. He has a much more stormy course and actually may well not recover fully, and he may well lose his job, so spiral down that socioeconomic gradient. So I put it to you that both of those individuals have succumbed to the 18-week pathway, but their outcome has been very, very different, and we've fueled inequality. So we know that there are many factors, clinical and non-clinical, that drive health inequality. We know what they are. Our challenge is how do we use them in order to schedule and influence healthcare. And we built a tool that actually built upon the process of clinical prioritization, but then added factors that drove inequality. So at the outset, we promise everybody that they will get the NHS constitution. But then above and beyond that, we use factors that will influence how we schedule care. So here are two patients, one waiting 15 weeks, the other 47 for the same procedure. And traditionally, we'd say the patient waiting 47 weeks gets prioritized in their care. But now let's put a bit more information into our tool. The patient waiting 15 weeks has 7 comorbidities that influence outcome. They've been into A&E a few times with their condition. They've also got another potential diagnosis of cancer, etc., etc. Now, if you use that data to tell you which patient is likely to have the worst outcome, we are likely to schedule the patient waiting 15 weeks ahead of the patient waiting 47 weeks. So we've built a prioritization tool, and I know other systems have done the same. But we use these factors, both clinical and non-clinical, to schedule our waiting lists. So we know that we don't just schedule based upon simple factors such as waiting time, but we schedule based upon the factors that determine health inequality. So we've developed a waiting list scheduling system, which every day will prioritize our waiting list based upon potential outcome. And if you look at what's happened in trauma and orthopedics over the course of a year, more deprived patients were waiting longer, the red line at the top. But what we've done by applying the tool is actually narrow the gap between IMD 1 and IMD 10, but we've actually reduced the waiting time for everybody as well. So we've restored services actively, but actually narrowed the gap as well. So we have lots of ambition in terms of restoring with respect to RTT, but also doing better clinically and in terms of inequalities. But actually, can we take it a step further? And the step further is, can we use clinical status change to influence dynamic waiting list development? So can the waiting list be agile as well? And we've got potential systems whereby GPs and patients themselves can influence their position on the waiting list by influencing what we do. And then furthermore, there's a step about social value judgments. So if we have a patient from a deprived background who's about to lose their job because they can't get their hip surgery, should they be prioritized over somebody who isn't? So we're starting to put the question of why patients need healthcare and what's important to them as a driver for achieving that healthcare intervention, rather than just the provision of healthcare alone. So the social value judgment in terms of impact on employment, education, carer status, etc., becomes really important. And this is just a QR-coded tool which gets sent out with every outpatient letter so that people log on and they get access to prevention if they haven't had it throughout the pandemic, but also an update if they have had it. So we make it so that every contact does count. And this is just some of the narrative that exists, because we haven't done this as a provider alone, but we've engaged patients and citizens on this journey. And it's remarkable how accepting the wider population is when you actually tell them why they are where they are on that waiting list. So, Jim, I hope that's been a really quick rattle through about what we've done and why.
Excellent. Thanks, Kieran. So we're just going to quickly move through the other speakers and then we'll open it up. So, Sarah, Manchester.
Okay, can you hear me? Yeah. Okay, so in Manchester, we are a merged trust looking at a population that is incredibly diverse, both socioeconomically and ethnicity, in terms of the north to the south of Manchester. And when COVID hit, we put in what we call an elective mesh process, which was basically looking at the allocation of theatres across the trust, 99 theatres in totality in terms of how we allocate those. And in the first instance, we allocated those based on clinical need, based around the FSSA guidelines. So P2's got priority when we only had restricted theatres. And then as we came further online, we were looking at the long waits in terms of 104. But that didn't quite, if you think about all the guidance that's come out about ethnicity, and when you stop and think, that didn't allow us just to tailor our allocation of theatre capacity and space to the right people, given all of the things that Kieran's made reference to. So what we've done is each theatre has a panel which does allocate theatres based on clinical need and length of wait, but it is also tailored now to be actually, in terms of each surgeon can then put forward the reasons why their case needs to be done, and so we can tailor that around all of the factors that that's just been made reference to. So that allows us to move those patients up the list, as it were. It's certainly nowhere near as sophisticated as the model in Coventry, but it actually allows us to do that. We also reflected back on the patients that we do treat during COVID, and actually we were quite reassured that in terms of socioeconomic factors, that didn't seem to indicate why you got. I mean, my biggest worry was through COVID, all we treated was middle-aged white men. And actually that wasn't the case. We did treat and allocate accordingly. But as we looked at the data even further, if you look at the outpatient data, which is where we did see massive differences in how patients accessed healthcare, in terms of actually, if you look at the cancellation rates around women, around some of the deprived areas, you could see that their waiting times to actually get to that first outpatients was really, really different, and their experience was really, really different. And so we've shared that data and we're socializing that data so people actually now understand that I'm an old surgical manager, so I used to treat from the top of the list, 2 strikes and you're out. And actually now we're moving into a world where that isn't acceptable, and we are socializing that data to make people think differently in terms of how we allow patients to access our services. We still haven't systemized that, but the fact is we've got multiple pilots going on around diabetes and things like that to just make the whole trust aware that there is more to waiting list and waiting list treatment than that, that RTT date. I'll stop there. Thank you.
Thanks, Sarah. And Nicole, a primary care perspective.
Hi, and to be fair, I think I've got 5 minutes, probably less than that. So to try and give you a broad brushstroke of sort of the whole primary care agenda, I probably haven't got enough time for that. But I think, as Kieran said, we fundamentally need to acknowledge that the way we deliver services is inequitable as a broad brushstroke. In the past, as we've gone around commissioning services and designing them, we haven't always done that with equity as that guiding principle. So, as we start to recover services, whatever they may be, if we do nothing but the same, we'll surely widen that health inequity gap. So, if it is our guiding compass and we need to do something different for the future, what's next? And I think Kieran's given us some examples of how that could look. But I think it's not just about looking at activity and access, but really about equity of patient experience and patient outcome, as these really got to go hand in hand. I think from a primary care perspective, we talk less about equity, we talk much more about health inequalities, but really in order to tackle the latter, we really need to be thinking about the former. And so I suppose I would say this is a primary care GP. Can we go a few steps back and think about the whole patient journey? Because I know, we're talking about steps forward in really looking at waiting lists, but for most patients, their journey starts much earlier than that. So how do we start to think about what happens right back at the start? If we're going to consider health equity to treatment, whatever that may be in its broadest sense, and that's, again, before someone hits the hospital, what do we understand our unmet needs to be? What are our patients' population, why are they not coming forward? Do we really understand what those reasons are? You know, have we put anything in place to remove those barriers? You know, I think it's something that systems and primary care really did well through the COVID vaccination programme. So, you know, what would a similar approach look like to patients coming forward for referral for treatment? You know, do we really understand as systems what the health needs of our local communities are? You know, what's the data and what's the local intelligence telling us? I'd suggest really we're at the foothills of this. But if we're ever going to really turn the dial on equity and health inequalities, then we really need to pick up the pace with this. As we'd sort of said at the start, it's now about doing something. Primary care is really well placed to support this. We hold a registered patient list, we have detailed knowledge of our local communities, we are an excellent source of primary care data capture, and we do have that very much holistic approach to delivering care. But really, if we're going to look at that as a much broader agenda, then we need to think about the time and the resources that primary care might need to focus on it, because sadly at the moment it is somewhat lacking in today's primary care landscape. I think really talking as a GP, I'd be lying to say that the waiting list issues aren't causing frustrations across the system. This isn't just an issue for primary care, but what I would say is it is felt acutely because we are that kind of first port of call for our patients when there are issues. I'd say that there isn't a clinical session that doesn't go by when one or two patients haven't been in touch to ask about their waiting list times, but really more importantly to explain why their conditions have deteriorated. And that does mean that we are seeing more patients coming back to us to need extra support and care, but also to a certain degree what we're also seeing is some of their frustrations about the status quo, which obviously they're wanting to vent, and that in itself causes issues for us as primary care, but also for our patients. So, you know, the work that's happening in the hospitals is really felt, but also held in primary care because, you know, as these patients are waiting, we're the people that are providing them with that support. So, you know, that's, again, one of the reasons, many reasons that we're seeing primary care demand really soar post-COVID. So, you know, how is this handled? What do we actually do in primary care? Well, each of those contacts does require that kind of personalised conversation, to think about that kind of holistic approach to the patient. It isn't just about their condition. And again, we're having to, you know, as these guys are doing in that kind of prioritisation, each time have that conversation to understand whether we need to be supporting expediting a patient up the waiting list. I think the other thing that we're hearing is from patients who are just getting in touch with us to say, actually, somebody told us, the hospital may have told us, that actually, could you just write me a letter, doc, because actually that will get me my treatment faster than it is. Unfortunately, that isn't the case. We all know that's not so, but again, that's something we need to work through with patients on an individual basis. So I think, you know, a lot of that conversation that you're having about prioritisation is happening already in primary care. I suppose my question would be, if we're doing it there, how are we communicating it in a systematic and robust way to our secondary care colleagues? Is there more we could or should be doing with regards to that in primary care? You know, again, as you'd said, it's not just about somebody's dodgy arthritic knee. It's about John, who's a self-employed plumber, who's struggling with his finances, who's looking after his 4 kids, who now can't work. You know, he's come back to see me to basically say, you know, I'm really struggling, doc, with my mental health. And I suspect that he lives two streets down from somebody else who, again, is struggling with a similar situation. But actually, between those 2 streets, the deprivation levels are significantly different. And do we actually do something about that? I suspect not. Certainly not from a primary care perspective around deprivation, but we absolutely do understand that much wider socio-economic sort of landscape of most of our patients because we know them very well. So, you know, these are just examples of things that we're seeing every day in primary care. We will absolutely continue to support our patients, whatever their personalised needs might be. We do this day in, day out, and we do it extremely well. But I think we need to acknowledge as the waiting lists grow, we're having to have more and more of these conversations, and that is obviously having an impact. I think whatever we decide to do around health equities in systems, I'd be advocating a very much joined-up approach, and that's between primary and secondary care, and if I'm honest, all providers that provide care for our patients. Patients don't operate in silos, and it's good to hear that you've absolutely been having those conversations. But most of their care actually sits with us. It sits before we refer them, it's while we're waiting for them to be treated in, and it's actually afterwards. So actually, we do need to be involved, so please involve us very early. And not just involve us, involve our patients, because, you know, we're having those conversations with them. We need to make sure that we take people with us. We need to be open, we need to be transparent if we're making any changes based on health equity. You know, they need to be fully informed of what it means for them and why we're going about changing their approach. So my plea would be 2 Ps really. Always think, have I involved the patient and have I involved primary care? Because if you haven't, please could you have a rethink.
Excellent. Thanks for that. So Caroline, a perspective from Age UK.
Yeah, hi. Thanks very much, Jim. I suppose I'm the outsider perspective. What did I love about what Kieran had to say? I loved the fact that data is king and you're really using data. I loved your realism, the fact that you didn't talk about suddenly there would be a magic solution to all of this, but if we could stop health inequalities becoming worse, that would be an achievement in itself, given what we know about and the evidence you presented too about who accesses health treatment rather more readily than others. So I think that I love that as well. And above all, I think I love the fact that you talked about a whole system approach and the fact that in Coventry you're using the challenge of trying to grapple with these waiting lists as a way of thinking about how you do everything. And surely the ICSs ought to be thinking about this a lot. And, you know, I loved what you said too about primary care needs to be absolutely part of the mix. So far, so good. The bits I'm a bit more sceptical about, I suppose, are the extent to which you can validly use non-clinical evidence and data for individual judgments about, you know, is it him or her? Or because I think the problem with that is it incorporates lots of value judgments and it's all the unknown unknowns that I think are the problem. And obviously, you'd love to have a situation in which it's blindingly obvious that they're much more deserving than the other person. I don't think life's like that. I think there's lots of very complicated things going on in lots of people's lives. So I'd be a bit sceptical about that. And I'm also bearing in mind what we hear from the public, which is a lot of worry about being on a waiting list. Frankly, even more worry, if anything, about not being able to see a GP or not having a meaningful conversation with a GP. So completely agree. You know, if you can't get into the system in the first place, which is what we hear a lot, frankly, from a number of older people, then, you know, that's a pretty important starting point. But also a sense, not really any understanding of all the enormous complexities that you guys are having to grapple with. You're having to think about very complicated things, but from what we hear from the public, they've got no conception of any of that, nor do they particularly have a conception of the fact that you're trying to recover from COVID. COVID's finished, it's done, so I should be getting my treatment now, shouldn't I? Is quite often what we hear, which I'm sorry to have to say that because I'm completely clear about what your realities are that you're dealing with and how incredibly difficult it is. And thank you for all you do. But I think in terms of a reality check, that is what we hear. From a lot of people. And it may well be, as Kieran was explaining, that you can have local conversations and help explain to people what you're doing and why you're doing it and overcome that. But the starting point from the public that we pick up, for example, through focus group research that we do on a national basis, is no understanding of any of that. And actually a lack of patience with the system as it is now and a desire to see it work really well for people. So I'm sorry to be a bit of a kind of damp squib about that, and I wish you well, and anything we and others can do to support you, we'd love to do. But I think this is really, really difficult, and I think it would be naive of me not to say that, and I think you deserve to hear the truth from me, so that's what I've said. Thank you.
That's great. Lovely different perspective there. Saffron, can you wrap this bit up, and then we'll open it up into questions.
Okay, thanks very much, Jim. So I really do appreciate Caroline's words, actually, because it is that reality check is so important, isn't it, in terms of how the public responds to those providing the services. What I'm going to focus on, what I've been asked to focus on, is the national perspective for trusts. So how does it look across the piece for trusts? And I found Kieran's presentation absolutely fascinating, and I think what you're doing in Coventry is really good example of how you're using data. You're really getting granular and really looking at how health inequalities can be tackled and your waiting list can be brought down in an equitable way. I think what I'm going to focus on now is some of those specifics about how it looks for trusts, then also look at what trusts are grappling with in terms of the wider system and sector pressures, and also talk about just beyond acute trust, what it means mental health, ambulance, community services as well. And I know we're pushed for time, so I'm going to rattle through this a bit. Helpfully for this conversation, a little while ago, NHS providers actually surveyed provider trusts about how they felt about tackling health inequalities, waiting lists, but health inequalities more broadly. And we had a really high response rate, which I think says something in itself. And I'm really struck by how health inequalities has been the theme that's run through everything I've been at this conference this year. I was chairing a session on digital boards yesterday. All we talked about was health inequalities, actually. So it's really clear to me how high on the agenda this is. We asked trusts what they thought the barriers were in terms of their ability to proactively address health inequalities. And it's really telling. 65% of them said that it was wider system pressures and operational challenges. So there's a prioritisation point there that we need to think about and come back to. I think critically, and this has come up, it came up really in Kieran's presentation, which is 49% said the availability of data to understand health inequalities in their trust was a barrier, 48% availability of the same data across the system. So there's something about data availability and what that means for trusts. Something really important for the role of the central bodies and those who hold people to account here. 42% said there were really unclear accountabilities for the outcomes for health inequalities. And I think we need to think about that. And 40% said that there were conflicting priorities from national regulators. So if organisations are being pulled in different directions and the priorities are misaligned, how do they then crack on with tackling health inequalities, crack on with the job of recovery when they're being pulled in different directions? 40% said lack of operational resource. We know that that's a frequent refrain, but it's not one that we can overlook. And then 30% said that it was lack of expertise within their organisation. So I think that gives you a good sense of where trusts are landing. And this is a national picture, remember, it will be different. And I think Coventry shows us that some trusts are doing it really, really well. Some systems are doing it really, really well. But we've got to kind of float the boat so that everyone is really improving and managing to push forward with health inequalities. Some of the qualitative feedback that we got in that survey was really interesting. And one comment I thought really summed it up in terms of some people's attitudes to tackling health inequalities, where clinicians needed reassurance that it was okay to do what they were going to do in terms of their traditional approach to waiting lists, and then the new approach using data and tackling health inequalities. And I think that's something we have to bear in mind. This is a massively different mindset for many clinicians, so we need to be bringing them on side. But I think we have to also remember that tackling health inequalities comes alongside the whole focus on recovery and speedy recovery against a backdrop of huge operational challenges and pressures post-COVID, post the longest and deepest financial squeeze in history, the ongoing mismatch that we've got between capacity and demand. You know, before COVID, targets were already going south, so it's not like we're in a new situation here. It's been exacerbated. Workforce, I don't think we've mentioned that enough today, really. Workforce shortages are the kind of perennial challenge that we're facing. And also, critically, and Caroline and I were talking about this earlier, social care challenges and the flow through hospitals in terms of social care. So those are the wider factors that intersect with trust's ability to tackle health inequalities. And I think we have to bear that bigger picture in mind. And then finally, from my perspective, from the national trust perspective, it's really about what's going on in those other sectors as well as just acute hospitals. We know that waiting times to access mental health services are really skyrocketing. Community trusts are incredibly challenged, and you only need to listen to the news today to know and understand what's going on for ambulance services. And they all play their part, a really critical part, in the the NHS and social care ecosystem. And if we don't get that right, then we don't stand the chance that we need to have to tackle waiting lists and to tackle health inequalities effectively. I'm going to finish on a positive note, an optimistic note, because I'm always accused of being the merchant of doom and gloom. I'm not. I think that what I was really struck by in the survey that we did of trusts was the fact that this was top of their agenda, despite all of the other priorities. They were incredibly optimistic about their ability to grasp this, that they wanted to be able to focus on their role as trusts in systems and be able to collaborate, because they recognise that it's only with primary care, it's only with the third sector, it's only with the other organisations on their patch that they're going to be able to tackle both the backlog of care in hospitals through the health inequalities lens, but across all of the services that the NHS provides. So I'll stop there.
Excellent, thanks Saffron. So we'll kick this around for a couple of minutes. There's some questions in Slido already, so we'll allow them to build up a little bit, and then there'll be an opportunity to open it up as well. So just to break the ice, and Nicole, the worry I have in all of this isn't that organisations are conscious and developing ways of making sure we manage this appropriately when we know about the patients. It's the patients we don't know about that we really worry about. So from a primary care perspective, is there more we can do together in your mind to make sure we are actually trying to find people we should worry about?
So absolutely, of course I'm going to say that. So I think there's that bit about using that kind of joined up data. So for example, in our system in Nottingham, we have all of our practices that are providing that data about our patients. So we can start to understand, you know, what does that look like at a much more granular level. But we have to kind of marry that together with what do we actually know about our community health needs. And so that's working together with public health colleagues who really understand, you know, do the two tally together and where are the gaps? And then I think there's that bit about the work that we did through COVID, which is that kind of outreach. So actually, it isn't a one-size-fits-all. How I communicate with one patient might be very different with another. So for some, you know, a text might work. For others, that very individual conversation works. For some, actually, I need to go out and have that conversation in a more outreach way. And we did that very well. But actually, it's not just about primary care. It's about using everybody that works in that community. So we had a very good example where actually we used faith leaders to have conversations because they were the trusted people in that community. So actually, if we can sort of tap into that approach, why can't we do it for other things?
Excellent. So that involves a lot of work, doesn't it?
It does.
Saffron, in the context that we've got more work than we can cope with, what's your view on finding more work?
Well, I think if I could solve that problem, Jim, then it might be somewhere else. No, I think, you know, it's absolutely that's the biggest challenge, isn't it? That we know that we know that there is a lot of unmet need out there. So how do we build that capacity? And actually, it's not going to be an overnight transformation, is it? And I think we've all been talking about this is an iterative process, and we need to build capacity. And I think one of the ways in which we build capacity, apart from trying to develop the workforce so that we are deploying them differently, so we're thinking about different ways of doing things, and I think Kieran's presentation actually was a really great way of looking at how we really tackle the challenges that are there using the data that we've got. But it's about getting upstream, isn't it, really? So it's about getting to people early enough so that their acuity isn't so high that they actually take longer to treat, that it's more complicated to treat. So I think we need to get ahead of some of that. And I can only see the solution coming through building capacity in systems, so trusts working in systems, working together, because it's that prevention route that we see through from, you know, whether it's in the community, into GPs, into secondary care, actually getting upstream of that and saying, we know the problems start here, let's tackle them. But that's really hard when we see public health and local government having had their budgets really significantly pulled back. So in a sense, nothing starts and finishes just in a trust or even just in a system or even just in a county council or across a patch. It actually is the decisions that are taken at the top have massive ramifications for what goes on to, you know, one of the people that Kieran was talking about who finally get their operation. So it's about getting upstream, thinking about prevention and thinking about how we're investing so people don't get so unwell and we can treat people more quickly.
Great, thanks for that. Sarah, in the completely imagined downward pressure of performance on you and your organisation to reduce long waits, how challenged did you feel on focusing on the things that you've described and the making sure people weren't disadvantaged in prioritisation versus the need to get where you needed to be?
I think I think the pressure is huge. If you think we had the largest waiting list we're the biggest trust, but we had proportionately a very large waiting list and a very large backlog. And I think part of the reasons MFT was formed was to look at that inequalities in terms of across the city. But I think we are conflicted, and I said it previously, I'm an old surgical manager and my job was to take from the top and make sure I work down, and having that conversation about actually this patient is more needy than that one, and how you differentiate that one is a really valid point. So I think the need to do that is really, really strong. The will to do it is really, really strong. But actually the mechanism on how we do that and how we systemize it is still unclear in my mind. I think we're playing at it is not the right word, because I think we're taking it seriously, but how we systemize this so it doesn't become that it's Mr. X doing this because of Mr. Y is going to take some time, and I actually can't see that in my head yet. I can say the words, but I can't actually comprehend how we will do that.
Okay. We're going to save you the last, Kieran, so don't worry. Caroline, if your job is about looking after a large and important segment of our society, and you've got colleagues doing that for other segments of society, how do we avoid falling into the trap of looking after those who've got the most articulate, strongest, loudest voice at the expense of others?
Well, it's a really important question to which there's no simple answer, but I think so far as older people are concerned, as some of my colleagues on the panel have already said, you know, the older people I worry about the most are the people who are at home behind closed doors, who have, you know, comorbidities, they're in declining health, they often have care needs, they didn't get treatment particularly during the pandemic, they may have lost their care and not got it back, or there's not enough of it, or they're not getting it at all. And so I think making use of all the people who interface with those older people is really important. So, you know, a big shout out from me for community health services, for district nurses, for OTs, for physios, all these people alongside primary care I think are fantastically important. And there's some rays of light. I mean, I don't want to be university negative about all of this. So, you know, some of the things that were tried during the pandemic or got a bit of a boost, virtual wards, hospital at home schemes, anticipatory care, all those sorts of approaches do have a big role to play in reaching people who otherwise would not be reached and who are very often not digitally included. It's important to remember that 3 million over 65s are not online and are unlikely to be. So there's no, unfortunately, from a delivery perspective, it's very useful and tempting to just use technology and text and all the rest of it. And that's fine for lots of us, but it isn't fine for everybody. So, you know, that would be what I'd say about older people. And as far as everybody else is concerned, data is king, as we're hearing on this panel. So using data in an appropriate way to correct, I think, to do course corrections when it appears you're going off track and some groups are getting more preferential treatment than others, I think is really, really sensible. But I would be wary, I think, about how that's communicated. I think you've got to get the comms right to the public about this, and I think you'll probably need all your local partners on board to help you do it, because otherwise there is a potential threat to community cohesion, I think, if it goes wrong. So I think, you know, working closely with local government and with faith leaders and others is really, really important, because everybody wants to feel it's fair, but people's conceptions of fairness are going to be very different depending on who they are.
Yeah, brilliant. We're going to move to Slido now, and so the first question on Slido actually is a very good fit with what you've just said there. So this is for you, Kieran. So can you expand on how patients and communities have responded to making social value judgments to inform the list, and do they get what you're trying to achieve?
Yeah, so I'll probably briefly mention that Ipsos Mori are about to publish a report based upon the engagement they did with over 500 citizens on what we're doing. And actually the first thing to say is that the citizens welcomed being part of the conversation, because too often they felt the NHS makes decisions in isolation of engagement. So I think it was fantastic to hear the range of views. And of course, there was some contentious debate about saying, well, I paid my taxes, so why should somebody else jump over me on the waiting list? And we used a lot of hypothetical scenarios, Norman, William, we used other scenarios and avatars. So we made them real examples, and actually people's conscience started to come in to say, I can't legitimately take my place on that list, knowing that there is somebody else who actually in some cases may die as a consequence of waiting another 2 or 3 months. So I think my answer would be engage the public, engage your patients, and engage your communities, because they will understand what we are trying to achieve here, and they will welcome engagement when they know it's much more complex.
Excellent. Next is a question from Nick Catuno, which asks, what would success in tackling health inequalities actually look like, and what specific measurements are we using, and how long will it take? So it's, I don't think any of us are really in good enough shape to be able to answer that properly, but you're further in than a lot of people, Kieran. So have you got as far as trying to work out what success might actually look like, how you'd measure it?
I mean, it's complicated, and there are huge dashboards, aren't there, Jim, here? But one of the early things we can measure are access targets across different groups and different pathways. So there are things that we can measure within 3 months, 6 months, 9 months. And then in the long term, of course, we have all the population health data in terms of morbidity and mortality. So there are suites of dashboards, they're out there, they're all evidence-based. We've just got to pick them up and start using them.
Yeah. There's a question from Amy Critchley. Moving to outcome-based waiting list management from standard RTT is a huge shift in mindset. How have you managed to get your systems to engage with this? Again, I think this is a bit of a work in progress, but Sarah, I'm very aware of the great work of the collaborative in Manchester, your alliance together. Can you just talk through how that worked with colleagues across the system?
Yeah, so thanks, Jim. So we have good engagement across GM in terms of working as a system, and certainly health inequalities is part of our recovery plan, where we have representation from councils, from GPs, and trusts to look at the data and to share that and to talk through the issues, because there isn't, I know Coventry, you've got a bit of a magic answer, but we haven't yet got that magic answer for us. So the fact that we're all exploring the data together and seeing what it means and seeing what we can do, it's small steps, but it's the right small steps, and it's a lively conversation, and it needs to stay like that.
Great. And on the data front, Saffron, this is for you. This question that says, we've heard a lot about data around inequalities at this conference. Does Saffron, I'm not sure why they picked on you, by the way, but does Saffron have further insight on what type of data surveyed trust felt was lacking?
I think that's quite difficult to answer, but I think that the broad sense is that there is a need to work with different types of data now than the data that we've traditionally worked with when we're looking at waiting lists. So it's that sense of understanding population-based data, understanding the bit about unmet need, understanding where we go to find the people who aren't appearing. And it's also understanding, the bits that Caroline was talking about, how do we intersect with, say, the voluntary sector, third sector that has a lot of data that is based on the communities and the different user groups that they represent. So I think it's that shift from solely clinical data into the more population-based data, or that cut through it. That's certainly the sense that we got from our survey.
Excellent, thanks, Saffron. So we've got a bit of time to open it up for the audience. There's fixed mics apparently in the room. I can't actually see where they are, but hopefully you can if you're in the audience. Does anybody have a question for the panel? Anybody? Yeah, okay, number 1.
Thanks. So I'm Julie Hankin, I'm Medical Director in Cambridgeshire and Peterborough Mental Health and Community Trust. I just want to pick up what you were talking about earlier about those patients who aren't presenting into the lists. So we've been spending a lot of time digging through our eating disorder data because of course we're seeing a huge surge. And what we're seeing is very clearly that surge is coming from our affluent GP areas and universities, not the THENs and the areas out with really vulnerable populations. And we know they're there as well. And I think one of the things that is concerning us particularly is although this concept of eventually we'll be able to get to prevention and getting ahead by doing that work, what we're going to find initially is like when we started up assertive outreach, a really high complex needs group that will take some very intensive work as we're going forward. And I think I suppose my question for the panel is how do we plan that into services then when at the moment we're struggling with what we're already set up and resourced for just for what comes through the door, saying to those clinicians, here's this huge extra workload I've found for you, is going to be really difficult.
Yeah, absolutely. Great question. Kieran, do you want to start that one off?
Yeah, Jim, I think that the profile of services we're providing has changed, hasn't it, as we emerge out of COVID. And it's going to continue changing. Clinicians are seeing it and dealing with it on a day-to-day basis. I think where we are slightly slower is having the commissioning policies and the processes wrapping around those emerging needs. So I think we've got to have agile development of commissioning and integration policies. So the eating disorders is a great example here. So yes, the affluent areas are sending patients into the more elective case pathways and referral pathways. Actually, the less deprived communities are coming to A&E, and we're seeing kids with eating disorders and the physical consequences of eating disorders in our A&E departments. So the need is there. What we've got to do is develop services and then move more upstream to say, how do you get everybody to access those services? And I think this is about putting the money in the right place. And let's have a really honest conversation about saying, if we want to get the same outcomes for all of our patients, we've got to do different things for different populations. And the money has got to be inequitably distributed across our systems if we are going to address health inequality. And furthermore, our workforce has got to be inequitably distributed. So we know that the inverse care law in primary care still exists 30, 40 years after Julian Tudor Hart defined it. The same happens in secondary care. So I think there are some really big ticket questions that we've got to start having debates around. Money and workforce, we always say, are problems. But the reality is I don't think those issues are as bad as we think we are. But we need a paradigm shift in our thinking about how we utilise both of those.
Excellent. Saffron, and then we'll go to the next question.
Yeah, I think it's a really helpful question, and I think it really highlights the particular challenges facing mental health and community services more broadly, which is when we think about setting access targets or, aspirations for acute care, for physical health care, they're absolutes. We're talking about treating 100% of the population, and it's what people wait for. We already set it at a level where we build in a care deficit for those services, because the aspiration is actually to treat between 2/3 and 3/4 of people with mental health conditions, rather than the absolute, rather than the 100%. So we need to think about that in the context then of demand shooting up. So, if we're unearthing further demand, the capacity that's needed in mental health and community services is really going to need to grow if we're going to actually treat everybody who needs that treatment. And we mustn't forget that, because it's that inbuilt inequity, when we're talking about health inequalities, around those differences between the treatments, that really does need to come through in this conversation as well.
Yeah, excellent. Number 2.
Hello, I'm Carolyn Green. I'm from Derbyshire. I'm a chief nurse in mental health and children's. So I'm going to build on some of my colleagues from Nottingham comments. When I was listening to your presentation, there were a few thoughts that came to my mind. So I know that when I set up a COVID specialist vaccination centre for individuals with mental health and learning disabilities, I had to ask them 17 times to get them to be able to have the vaccine. There wasn't one question. So your commentary about 2 and you're out, and about how we were able to do that, resonated with me. For me, I think our future and my own homework is to join up with our acute care services on a couple of levels. So to think about individual on their waiting list, how we can flag electronically or in a systematic way individuals open to secondary mental health, so that when those appointments come through and people aren't coming, that we can help people get there. But my workforce is really busy, and they don't necessarily have the capacity to enable that, to be able to get people there, because our referrals are through the roof and we have our own waiting list issues. So for me, we have policy and developments in peer support and expanding individual placement support to get people with mental health issues and lived experience into work. So how can we incentivise apprenticeships to join people in your waiting lists to help people travel alongside and get people to their appointments and not rely on the professionally qualified workforce to be able to try and do that, and us to think laterally about how we can use ourselves as anchor organisations to expand and help people into work while helping us recover our waiting lists. I also think my own homework is to look at our own mental health waiting lists, take data from colleagues in the acute sector for cancer waiting lists and other waiting lists, and prioritise their psychological help, because their outcomes will be better if we have seen them earlier to be able to help them through their physical healthcare treatment. So my ask to you and to members of the audience is to think about how we think bigger than the elective waiting times and how we collect some of those aspects, which all of you have absolutely talked about, but do it on a slightly larger scale. So it's a bit of a commentary, it's a bit of a questions, but I would welcome reflections.
Excellent. Thanks for that. Nicole.
So that's music to my ears, because actually, you know, we've talked about sort of what's happening in Kieran's patch, but actually I do agree it's much bigger than that. And I think that's hopefully where some of the work around integrated care systems sits. But again, it's not just about health, because, you know, we had a marvellous volunteers kind of response through COVID. Actually, let's think about also how do we activate our communities, our people, to support other people with other needs, really. So I think it's about really thinking outside the box and taking this even wider than health. But I also think about us just talking to each other. You know, patients don't see it that they're seeing you in the mental health trust and they're coming to see us in primary care. They're just thinking about what their needs are, and we need to join ourselves up so that actually we're forward planning and thinking what can we each do to make their journey much simpler. So I don't think there's one easy answer, but I do think, you know, we really need to be thinking big, and we need to be thinking about connecting ourselves together.
Excellent. So I think I should be looking to wrap up now. We've got about 5 minutes left, so I'm just going to try and give some closing thoughts, and if anyone wants to jump in again, that's great, and then we'll wrap up and people can move to the next session. So first of all, I think we've heard some fantastic perspectives on this topic, and I think key issues from my point of view are we're all benefiting from the spotlight being on this as an issue, whereas 5 years ago definitely wasn't. So the last 2 or 3 years have really helped with that, and there's some emerging approaches and evidence and those sorts of things that can help. You do need, though, a curiosity, and Kieran used the word ambition several times in his presentation. Going back to the last question, I think trying to look at this as broadly and as comprehensively as possible, with a real desire to make an impact, whatever that means for your place, your system, your organisation. Data is absolutely key. So, you know, God knows how many times we've talked about data. The NHS is awash with data. It's very hard to access at times. It's incredibly hard to join up. So we've got a lot to do there, and really at a granular level, on Nicole's points, getting into communities around PCNs and understanding local nuance, I think, and that whole local tailoring thing. This isn't something that works everywhere in exactly the same place, not even for one organisation. So if you think the scale of Manchester, you know, complexity and diversity there is enormous, and we've all got our version of that. I was reminded of Don Berwick's thing in the conversation about you need to improve, you need method and purpose. One without the other is pointless. So with all of this, we need the ambition and the desire and a bit of a plan, etc. But you've got to have some methodology as well as to how you're going to get there as well. So I'd encourage people to just really think about what that local approach is, and we've heard a few already. And then I think on the foothills point that I think Nicole said earlier on, we are absolutely in the foothills on this. So I think we need to make a start, review where we are, adapt, change, do it again, adapt, change, and expect this to be, you know, a bit of an ongoing job, probably forever, but we're not going to nail it in one go. So if it's okay, I think we should end there. It'd be great to thank the panellists in the usual way for fantastic contribution this morning.
every night for 353 days. I heard.
Robbery in progress at Lakeside Bank on West Jackson Boulevard. Be advised, assailants are armed and dangerous. Getaway car is a black Pontiac Trans Am heading southbound on South Clark Street.
I'm not going to ask you to do it. There's about 100 people here. Because you're dotted all over the place, it hasn't got that kind of buzz it would have. So you don't have to do it. Some of you won't, and that's fine. But all of you who've got warm and generous hearts, if you could move into this front section here, it'll just give the event yeah. Oh, look at that. Oh, see? Amazing. Amazing. That was, well, what can I say? You've made my day. If you move in here, brilliant. And I promise you we'll finish on time, so you don't have to worry about sneaking out or anything like that. That's awesome. We will start in 1 minute, and thank you.
It's like we're the last ones on the
So, good afternoon, everybody. Thank you for coming along, and thank you for moving towards the front of the room, which gives us a great, more intimate kind of feel. So, I'm Matthew Taylor. I'm Chief Executive of the Confederation, and this is an event I've been looking forward to for some time because it's with my good friend Hilary Cottam, who's a social entrepreneur, a thought leader, an author most recently of wonderful book, Radical Help, which I think is on sale here.
Yes, I'm going to sign copies if people would like to.
Excellent. Where will that be?
Meet me. Apparently immediately outside, although looking around I can't tell where immediately outside would be. Is there a hall outside here somewhere?
We'll work it out.
Waterstones are there.
There will be a self-organising thing that will happen.
Brilliant.
Yeah? Because if we had to exactly tell people where to go, it would undermine the principle of your thought, wouldn't it, really? Yes. I'm really looking forward to what Hilary's going to say, and then hopefully there'll be time for me maybe to ask her a couple of questions, you to ask her a couple of questions. We could talk for hours and hours and hours, but I promise you, you will be able to go by 1:45 because I know people have got really, really busy diaries. So without further ado, with all the warmth and generosity in your hearts, please welcome Hilary Cotter.
Thank you. It's really nice to be here, and more people are coming, which is really nice. And Matthew's asked me to speak very quickly because he wants to be in conversation with me, so I'll do my damnedest. Let me get my clicker. So this is Joe, and Joe, I've brought Joe with me, as it were, because Joe needs his toenails cut. And last week, his GP, who I know very well, wrote to me, incensed. I get thousands of emails following Radical Help, which is kind of lovely and also challenging, but incensed by the impossibility of organising this simple task. And so the assistant head of community commissioning, I'm going to call them Jamie so as not to shame them, responded to her email for help by suggesting that the patient was given a leaflet from the National Podiatry Association so that they could self-care. Of course, the reason that Joe came to see his GP in the first place is because he can't self-care, he can't bend over, he can't cut his toenails, he's got balance problems, he's got epilepsy, and he's actually so ashamed that he can't walk and get his shoes on that he now barely goes out. And he was in hospital a little while ago for skin cancer. And despite his toenails, which are like kind of small horns curled over his feet, still nobody suggested that he saw podiatry the whole time he was there. So he was in hospital, and then nurses came into his home to bandage him, but it wasn't their problem either. And the idea of giving him a leaflet isn't going to sort it out either. And Jamie, the commissioner, wrote, quote, "I recognise that this is an approach simply of signposting. It's not ideal for older people who require support with personal foot care, including toenail cutting. But given the challenges, I think the above response, the leaflet, is reasonable and pragmatic." I'm not a clinician, but like most of you, I've read the data. I know that taking care of small things, unglamorous things, vigilance over diet, what's happening in the home, toenail cutting, saves lives and reduces the need for high-cost interventions. I've read the work of Atul Gawande, I'm sure that Jamie has, I'm sure that you all have. So we know that what Jamie calls, quote, pragmatic and reasonable is in fact the very opposite. Jamie is doing a sort of doublespeak in their refusal to acknowledge what Joe needs and the difference between signposting and care. So how did we get here? I want to come back to that, but first of all, I just want to tell you another story. This is Kate. When I first met Kate, she was slumped in a chair. Her eyes were cast down, and in a kind of monotone, she listed all her ailments. She too has painful feet, a painful back, she can't sleep, she thinks she's depressed, her weight has been creeping up, and most recently she's been diagnosed with diabetes. And I'm sure this story sounds also very familiar to you, because Kate's notes were full of the acronyms of modern illness, TAT, MUS, the records of countless prescriptions, each one written by a different and harried GP who is faced with the impossibility of actually helping Kate in the 10-minute slot allowed. We are not feeling well, and our health service is struggling to cope. And at the sharp end, GPs can reach again for their prescription pads. Commissioners like Jamie can numb out, refusing to acknowledge what needs to be done. But it's just not just we, the people, who are not well. It's our health systems too. And despite the dedication of clinical and support staff, the coming together over divisions, departmental divisions and hierarchies that we saw so clearly in COVID, the long hours, our waiting lists are spinning out of control, and we are hemorrhaging talented people, basic humanity and common sense. So we're gathered here together and kind of following it on Twitter, it's felt sort of slightly like a kind of salad of words: transform, improve, innovate, integrate, and I've heard, secret weapons, patient pathways. And I've been thinking, I'm very glad to be here, what is really going on here? And I chose the title of my talk, Radical Health, although I actually wanted to call it maroons on a toenail because I thought that might be more kind of apt to what's going on. Because radical means going back to the root of things. So I want to spend the time today asking what would happen if instead of focusing on fixing the NHS, we went back to the very first principles and asked, how do we create and sustain health? And how, given everything that's going on that you all know about more than I do, can we always attend to the small things, which was, of course, what was intended by the founders of our systems. What does it actually mean to flourish as opposed to simply surviving? Kate was part of an experiment I started over 10 years ago, and setting up in GP surgeries, we asked them to send us all the people, their heart sink patients like Kate, that were suffering from a whole range of social, emotional, economic, and physical ailments that they couldn't address in a 10-minute slot. Recognizing that chronic conditions are part of everyday life, we didn't focus on any specific condition. And when we met Kate and the thousands of others like her, who eventually used a service we called Wellogram, we didn't actually even ask them about their health. We asked them to talk about their lives and what they would like to change. And so this is actually an image from the book of Kate sitting with Amy, her Wellogram worker. And Kate told Amy that she'd lost herself. And then they just kind of sat there in this sort of shared silence. And Kate explained how she's the carer for her husband and her son, and how, as she's become increasingly overwhelmed with those care tasks, things have unraveled for her too, and she's become ill. And this too, of course, is a very familiar story. And together they worked out a plan. Kate felt the thing that would most help would be for her to take up her embroidery again, just to have that moment to herself. And so Kate went off to do that, and Amy agreed that they would meet again in a few weeks. And this story is part of a pattern because all the people, Anne, Kate, whatever, who met through Wellogram, almost no one asked to choose a health intervention to start with. But very slowly, in every case, health improved. And the advantage of working in a GP surgery was we had all the data, so we could see that those improvements to health were sustained over time. Listening is what really this is about, and it takes time that busy doctors don't have. But the sense of being truly heard is empowering, and all the side disciplines tell us and have evidence that to make change, you have to have this open listening, which is the start of telling a new story about yourself. And through that story, you develop a sense of direction, a sense of how things can change, and you can make shifts in yourself and what you do. Amy is what I would call a relational worker. She listens, and through this active process, she forms a bond. And I think it's really important that almost every one of the thousands of people who took part in Wellogram knew exactly what they should be doing. They didn't need a leaflet or any kind of advice. They knew what to do. But practicing change and sustaining that change is really hard. And this is where the relationship comes in. So Amy knows that this is what's hard, and she knows that to do it, she's got to build a relationship with Kate. And when Kate came back the second time, this was a very early person who I sat through with, she said to Amy that she hadn't really expected anything to happen. She just expected to be told things. But she said that this is so much more helpful because that kind of bond and trust had been built. And so this was how Wellogram worked, with this set of simple tasks. Each one, the participant grew in confidence and went on to take the next task. In the beginning, nobody's ready to meet new people. But once confidence is built, finding good company is really important. And Wellogram is about weaving people together in the community at the right moment to continue that support and to continue the sustained changes. Operating at the level of, say, a London borough, Wellogram would cost £20 per person to year, and our clinical data, based on the long-run outcomes of the first 2,000 people, was impressive. Here's just some of it. So Wellogram is part of a growing body of work and evidence that shows how open, relational-based approaches in which workers have autonomy over their time, their budgets, and their work, and in which clinicians are deeply integrated in their communities, makes lasting change. This is Birgit Valle, who, as you can see, works in Norway. And Birgit is a clinical psychologist who leads a mental health service for families and adults in the Stavanger region of Norway. Like leaders in the UK, she receives a huge number of weekly emails from others in the system. They tell her about the new guidelines, the new approaches her staff should be trained in, new innovation methods, and so on. And what, of course, she notices is as these emails, this kind of flurry, this salad of emails keeps coming, The waiting list for her services kept on growing, and in the community there was a pandemic of stress and ill health. This was before the actual pandemic. And she also could see that her teams were suffering and overwhelmed by the workload. And she was thinking, you know, I've reached the top of this system. Is this really the best we can do? So she decided to go out and observe her services and then to sit in homes and listen. And the results were radical. The service introduced two things. First of all, they abolished all their assessment criteria. All the tools by which they managed their waiting lists, all the gatekeeping, they just let it go, and they invited everyone in. And it turned out, this is in a kind of big region, that inviting people in as opposed to managing the lists created less work. Of course, there was a kind of initial up, and then it kind of rapidly went down, in part due to the second factor. Clinicians practiced a rigorous form of feedback. Every patient was asked, not through a form, but through a qualitative conversation at the end of each session, what would be the best thing to do next. And this informed the next step of practice. And so at the beginning as well, I mean, Birgit, she's written a book called Beyond Best Practice, which I really recommend if you're intrigued to know more, would be worth looking at. She made mistakes, she talks very honestly about that. But the professionals, first of all, were not, some were really eager, and as in all systems, this is great, we can adapt, others kind of less willing. But really what happened overall was that most people wanted smaller interventions that were timely, and costs went down, and there's a very different culture in this service, and of course, the results, the health of people in this region have improved. She runs a podcast, which is actually where I've taken this image from, talking to other health leaders around the world that have taken these two similar steps. And then there is Buurtzorg in the Netherlands, a model in which nurses and carers work in self-managed community teams. I'm sure that some of you went to Brendan Martin's talk this morning about this work in the UK. But Buurtzorg was first started by nurse Josta Blok in the Netherlands in 2005. As health costs spiraled in the Netherlands and consultants and efficiency kind of drives and all the rest of it moved in, he wanted to provide a very different form of healthcare, one he was absolutely sure would be possible if the 30%, as he puts it, I would say it's higher in the UK, but the 30% of resource that was being channeled into bureaucracy was instead diverted to the front line. And with 4 nurse colleagues, he set up a non-profit and started to experiment. Today in the Netherlands, there are over 10,000 Buurtzorg nurses and carers. They work in small autonomous teams, making all the decisions about the work together, and technology is used in deft ways to support administration and learning. Communities taken care of in the Buurtzorg model need 40% less interventions when compared to other regions in the Netherlands, and there's been a 2/3 reduction in hospitalizations. The nursing teams are stable. They enjoy their autonomy and the pay is good because there's no extraction for management costs or for private sector profits. In Buurtzorg, the finance system is totally transparent. Nurses know what they have to achieve for good care and to support the business model to survive. And Jos describes this as a psychological contract. I know this morning that Brendan talked about Buurtzorg in the UK and how sometimes, often in fact, attempts to replicate the work have struggled because NHS commissioners haven't actually given full autonomy over management or budgets. But in the Medway region, the NHS Medway, something different is happening. And this morning, the nurses involved talked about how the system treats professionals today like children, but when given autonomy, what really different things can happen. Brendan, I think, calls this retrofitting innovation, because, of course, for so long, we always did give professionals, whether it's in the care system or the health system, this autonomy. So it's going back to what we actually know. Taiwan is another place where, despite really big cultural differences, this model has been successfully adapted for a new culture. These models are always less costly, but that, of course, isn't their purpose. Their purpose is flourishing, and then savings are a byproduct of a much better model. But many of them do come from parts of the world where relationships are strong and resources are very scarce, so there's an absolute imperative to think in a different way. An example of this is the community health work in Westminster, which has been started by GP Cornelia Jungens. So Cornelia, Connie, as some of you might know her, has borrowed from a very successful low-cost model that's been running in Brazil since 1994. She and her team have trained local residents. This is from the Churchill Gardens estate in Westminster. She's trained residents as health workers. And they make monthly visits to all other residents, absolutely regardless of need, in order to build relationships with the entire family. I think it's a model that could, I would say should, revolutionise population health. These are the shoots of a new health system. I'm sure everybody here has got their own examples in the places that you live and work. These are the stories as well that are told in the innovation boxes of formal reports. So I think the challenge for us here and now is how to bring the work of Amy, the toenail cutters, the community health workers, the professionals, with new ideas at the heart of our systems, from the margins to the centre. I think that we cannot fix the NHS. I'm sure that Matthew will quarrel with me later. What we need is a fundamental pivot in our thinking, in our systems, in our actual imagining of what health is today. So let me talk about the pivot. When modern industrialists, the designers of our digital systems, spot a fault in their designs, they have to decide whether to persevere, go on, keep trying, or to pivot and change course. So the decision to pivot looks on the surface like a matter of reasoning. You know, what does the data say? Do we have the resources to fix the problem? Is it likely the fix would work? Would it be too expensive? Would it be better to start again? It all looks very logical. You know, let's get a toenail service up and running, because obviously if we do that in the community, it's going to save the NHS so much money. But the reality is really different. The pivot is about emotions, about embracing a failure in our thinking, our plans, and our mindsets, and starting again. It takes immense courage to pivot, even when the evidence and the data is right in front of us. Because the voices in our heads say, I've already invested so much time and money in this kind of way of working. Surely we should just do one more try, one more adjustment, you know, reorganize the system, have some different outcomes. Surely it's worth one more try. Just imagine the upheaval if we actually really try to change course. So in fact, the decision to pivot is so difficult, most organizations don't make it, and historically they do fail. A pivot, you see, is not just another word for change. The pivot is a very special kind of change. It needs a new vision, a different solution, and a very different economic model. But it does offer the potential for transformation. And the pivot also requires a particular form of leadership based on vision and collaboration. This person here is Chief Plentycoo. He was the last leader of the Native American Crow Nation. And Plentycoo lived through a time of profound upheaval. The buffalo, on which the Crow Nation were culturally and economically dependent, disappeared. There was nothing to hunt, nothing to trade with. None of the cultural rituals worked either because they were around the buffalo. Let's just hang on, let's hope. Let's walk a little further. Let's persevere and change something, many of Plentycoo's people argued. But Plentycoo's realized something much deeper, that an old way of living had gone forever. He knew that a radical plan was needed, and he also realized that the different set of possibilities were already present. His people had started new forms of learning, new forms of agriculture, but these things were unseen at the margins. So Plentycoo knew he needed to pivot and to champion these emergent new systems, and he was an amazing leader because he could, working with others, persuade his people to follow him. And this story of Plentycoo is told in a remarkable book called Radical Hope, written by the philosopher and psychoanalyst Jonathan Lear. And Lear writes, at a time of cultural collapse, the courageous person has to take a risk on the framework itself. Now, I'm not necessarily arguing that we're at a time of cultural collapse, but obviously we are on the verge of eco-collapse, and we are in a deep state of health collapse, of physical and nervous exhaustion. Many, many health workers are almost beyond collapse, and they're voting with their feet. And the business models which are underpinning our industrial health systems are also crumbling. They are industrial, vertically organized public systems, and they can't flex. They can't give the required autonomy at the front line or relate in new ways to the population. An extractive market model set the wrong incentives in siphoning off their profits and leaving too little to go around. So I think it's really clear now, today, that the shifts in our economic, social, and health realities are so fundamental that we need to take a risk on the framework itself. Like Plentycoo, we have to acknowledge that things are going to change way beyond what we can imagine here today. We know that we can't face the future in the same way that we've been doing. We can't plan another reorganisation. We can't bid for another pot of funding, hoping that something will change. With others in our community, with like-minded leaders, we have to open our imaginations to a radically different set of future possibilities. What I'm saying is that if you're a leader, I think you're leaders here today, it's not appropriate to persevere any longer with ideas of efficiency or new forms of payment or small innovation projects or workforce reform, whilst the rest of the system continues untouched. You can't work in a small place. You've got to bring that margin to the centre. You have to have the courage to address the profound redesign needed. And basically, we all need to take a risk on the framework itself. So I always argue that there are 3 reasons that we can't carry on. The first, obviously everybody here knows much better than I do, which is that the nature of the problems has changed. We have this model of the NHS, which is based on the idea of a cure, that somebody very well trained at the top of a vertical system can pass you a cure. This works very well in command and control, but it doesn't work when our health burden is no longer actually about a cure. When we need to prevent, care, support, this needs a completely different way of working. The second profound challenge is care. So Beveridge, the founder of the welfare state and our systems, didn't know how to address the problem of care. They talked about it for a long time, and in the end, they gave up, and they swept it behind the front doors, saying this will be the work, caring for small children, our elderly parents, neighbours if they need it. This will be something that will be women's work. But this system broke down in the 1960s when Helen Gurley Brown famously wrote that women in Cosmopolitan, women just want to go out and have sex. And that's still true, but what is different now, I think, is that men and women also want to care. And this requires a profound reorganisation of work generally and our social systems. Today, the lack of care can't be, as Beveridge did, hidden behind front doors. We all know it's threatening to bring down the whole edifice. But neither can care be delivered through new systems that are just some sort of replication of post-war NHS models, or through trying to stitch together threadbare public health models with exploitative forms of private care. Like Plentycoo, we can look around and see radical new forms of care all around us. Wellegram, Circle, Bortzorg, Shared Lives, Somerset Cares. I think you all know the models, and we need to fund them and support these new cultures to spread. The third reason we can't go on is poverty. Health is rooted in poverty and inequality, and the gaps between us are now chasms. Jamie assumed that Joe is old, as we heard in the email. But Joe, in fact, is exactly the same age as I am. But his life chances have been very different, and his body, his toenails, tell the score. Today, our health services are designed in such a way that they not only fail to address inequalities, they in fact create them. The porters, the cleaners, the carers, the thousands of workers on which our systems depend who are paid a minimum wage or less. This isn't only unjust, it creates ill health. And these are injustices of race and gender that were designed into our systems and have to be changed. Some of you may have seen the film Exposed. And it's really an incredible film. It's a film of black and brown nurses who tell their story of working in the pandemic. Your body is tolerated. Your value is economic. I'm just a number. If anything happens to me, it's not going to be long until they find another. If you haven't seen this film, I really urge you to do so. It's being shown in cinemas and it's available online. Because when we think about the pivot, we have to think about systems that take care of everyone, and that involves really thinking hard about these legacies of injustice. To do anything else is like pouring water into a leaky bucket. It's like hunting for the buffalo that are extinct. We can carry on hiring, we can go somewhere else to look for people, but nothing is going to change. So what can we do? Everything is possible. Just as in the time of Plentycoo, new ways of caring and supporting health are all around us. And despite the oppressive conditions and exhaustion, we know, and we experience it, I experience it, you experience it, you are it, The health service is full of extraordinary individuals, and you are leaders. You can ditch all this talk about pathways and improvement and transformation, and you can lead in a different way, one which will release the abundant resource that is actually all around you. So I'm just going to close, Matthew will be glad to know because he wants to talk to me, with 4 things that we could do that would actually enable the pivot. So the first one is that we can tell a new story. This actually is some work I've been doing in Barrow, where all together across the system we've come together to weave a very different story. Just as Kate found new ways to live and to flourish by weaving a story about her own life, we can do the same. And I don't think we should underestimate the power of a story in which we see our own lives reflected. That, after all, is how we got a health service and a welfare state. You know, it might have been created somewhere and designed in a room, but civil servants got nervous and people held, you know, the feet of leaders to the fire to make sure it happened. So if you're a leader, don't talk about fixing the NHS. Don't run focus groups or participation exercises about how to improve your services or your outcomes. Start outside the system where people are and create a real living story about what health looks like in your place. It has to be a baggy story, not a management document. It's a tale that resonates, that can bring together everyone in your system that is creating health. The dinner ladies with new ideas, the parish priest, the small group of local podiatrists who do want to set up a community toenail cutting service, a clinician with different ideas, a doctor's receptionist. Find them and weave your story. And, you know, you can talk to me afterwards about what kind of processes really can create that story. Secondly, organise horizontally. Build a coalition of the willing. Today, the health service is this industrial vertical system with power and resource concentrated at the top. And this made sense in the era in which it was designed, but it doesn't make sense today. Today, we need to think horizontally, to form new bonds between institutions, professionals, and the community. So don't spend time trying to convince others at the top of the system. Connect horizontally in the places where you are, and you will find the energy you need. All the models I've talked about today are dependent on new relationships between clinicians, public workers in absolutely the broadest sense, and the community. So thirdly, create possibility. Fund everyone that is bringing your story to light. ICBs, you have the power to do this. So don't have innovation pilots. Do as the founders of our systems did. Have a very clear strategy about how you're going to switch all resource from these old moribund systems to the new, to Wellogram, to those who want to create the independent board-sorg models, to the big valors that are prepared to throw out the rules and invent something new. Copy the work of Connie Jorgens. Take a risk on the framework. And I just want to say a quick word about risk, which is something that I could actually talk about all day, because today it's risk models, which are actually a comparatively recent invention or thing that came with market models into the NHS. And they work against change. They work against possibility because they keep focusing resource on managing that risk. It's like a spiral to the bottom and diverts from new possibility. But the thing about risk models is that they only work in conditions of certainty. And you are all of us are, operating in conditions of uncertainty. Aging, physical and mental illness, these are uncertain things. And no amount of data or modelling or talk of managing risk is going to help. A reliance on data-driven modelling leads large organisations, in particular, to make decisions on the basis of what is easiest to justify rather than what is the right thing to do. And those aren't my words. Those are the words of Mervyn King, the former governor of the Bank of England, and John Kay, a leading and very orthodox economist. I really recommend their book, Radical Uncertainty, for those of you who are trying to convince your colleagues to work in these different ways and to convince them that risk-based modelling is the problem. These are two very establishment figures, and they recommend ditching statistical models in favour of narrative, in favour of stories. They emphasise the role of humanity and intuition when we're in this period of radical uncertainty. That's what best serves us trying to think what to do next, rather than data. They understand that this is a moment of paradigm change. And my fourth and final point is to take care of everyone. If I had to sum up my own book, Radical Health, which obviously I'm hoping you all buy afterwards, which tells different stories to the ones I've told you today, if I had to sum up in one line, it would be this: take care of everyone. Because people are your and our precious resource. In our systems, I think it's really critical that we don't distinguish between those who are doing the work, clinicians, receptionists, so on, and those who are in the community and need support to create health. We have to grow capability in every part of our system. And just as Amy has to allow Kate to feel attended to before she can make change, so it is for everyone in our systems. If you're afraid that you'll be blamed for trying something new, if you're actually so overworked that you can no longer listen to your human instincts, if you're so badly paid that most of the time you're doing endless calculations in your head about how you're going to afford your rent and your heating, then you cannot be part of a healthy system. So if you're a leader here today, don't pretend your systems can cope. Listen and be honest with the people you lead. They have already shown you, under the pressure of the pandemic, how they can pivot. So ask them what we should all now do together. And I think that would be radical health. Thank you.
Not bad.
No, brilliant. So I'm going to ask Hilary a couple of questions, and then we'll open it up to you to ask some questions. And as I said, we'll promise to finish exactly on time. So, Hilary, my first question is, I was 2 weeks ago at a primary care practice in Merton in London, and during my visit, I met with health coaches. I met with social prescribers. I sat in on a meeting with patients who were being asked, to whom these services are being explained, but who were also being asked to become patient advocates themselves and join the patient advocate group that supported the work of the practice. Now, this is a very good practice, but this is not unique. If you go around primary care now, despite the pressures it's under, that these kinds of roles, coaches, social prescribers, people engaging with the community, this is becoming kind of mainstream. At the same time, where the kind of defining concept for change in the health service only 5 years ago was competition, now the focus is on collaboration. And indeed, that's the kind of core idea behind ICSs, collaboratives, place working. So I guess my question is this: why is none of that reflected in your talk? You know, either you don't know it's going on, which I can't believe because you're incredibly well informed, or you think it's all baloney. I mean, I'm just, you know, because actually, if I had said to you 5 years ago, we would be redefining primary care in terms of some of these kinds of roles and this kind of model, and trying to move towards population health management, if I had said that we would move away from competition to collaboration as the defining concept of the health service, I think you would have said 5 years ago, well, that's brilliant, you know, so why?
Well, one thing is I think I might have said some slightly different things 5 years ago because I've learned a lot in the last 5 years. I mean, you're asking... I mean, one thing is perhaps we live in parallel universes. I mean, I'm not saying that the work in Merton isn't great. There's always great work. We don't have trouble filling our innovation boxes in our report.
But this isn't innovation.
But I'd love you to come to...
This is the centrally mandated way in which we're trying to change primary care.
I'd love you to come to my GP practice in Peckham, and here's how it works. You can't have an appointment further into the future. So let's say you're on HRT and you know it need to be reviewed. You can't have that. You must call every day at 8 o'clock, and you must try and get one of the slots available. And after 8 o'clock, because obviously you're held in a queue for music for about 45 minutes, an hour, and if you're at the hour point, I don't know how long it takes to get to the point, that there's no appointments, then you're just told that you must go to A&E, which is really interesting. I mean, I think it's really interesting how, you know, ministers can say, oh, you know, we need to do primary care, but my GP practice still tells you to go to A&E every day. Or you can try again at 8 o'clock tomorrow. So that's one very personal experience. The other is that perhaps I should forward you my inbox from Radical Help, Because, you know, every day, whether it's from a CAM service or a primary care service, people are still being told about how to manage waiting lists, how to do new, complicated forms of kind of workload management, instead of actually kind of grappling the problem, which is that there just aren't enough people to do the workload. So I think that, you know, I'm not saying that brilliant things can't happen in the system. They are. I mean, I talked about the work that Brendan is doing, for example, in Medway. Of course, we know, and I've talked about Connie Jorgens, she's a GP. There are extraordinary individuals and extraordinary things are happening. But there's two, maybe three problems. So one is that work is currently heroic. Like, you are doing that by carving out a space in the system and supporting everybody. You're not really going with the flow of the system. However it might seem to you at the top, you're not. Culturally, you are going against the system. That's one problem. The second problem is that, and this is something that I don't think I fully realized 5 years ago, is that you cannot do this kind of collaboration in a system which is essentially a market-based system. That the targets and outcomes in our public systems, whether they're kind of actually run by the public system or whether they're run by something private that is badged as a public system, are essentially, you know, neoliberal market frameworks that are about competition, however it's disguised, are about kind of a linear kind of, you know, bit to an outcome. And in that culture, it's not possible to collaborate. I mean, it's not possible, but I mean, we're talking about system change.
I want to bring people in, but I also want to have an argument with you. So,
yes,
who's enjoying the argument? Yeah, okay, good. Well, shall I carry on with the argument and then, you know, so? I think you're conflating some things here, Hilary. Actually, is what I want to say. So so you talked about Buurtzorg, and then you talked in your talk about data and how data is a big problem. Buurtzorg is full of data.
I'm not against
data.
No,
hold on. Josterblock uses data.
Well, nobody's not going to use data.
No, but he uses data very powerfully. And indeed, the reason he is able to run a system with such high levels of autonomy is because he is very closely observing the performance of his teams and insists that they pull in a coach, not a manager, but a coach, to work with them if they're underperforming. So,
but it isn't like that, actually. Well, sometimes it's like that. Sometimes teams go wrong. But actually, it's a learning model. So you're already making it sound like some kind of alternative form of inspection that has been kind of imposed on teams. That isn't, I mean, you know, that isn't my impression, although I don't want this all to kind of be a conversation about Buurtzorg, but that isn't my impression. My impression is that, yes, sometimes that needs to happen, but generally, it's like the work that I do, which is that you've got autonomous teams who therefore don't feel oppressed and are very happy to say, this bit isn't going so well, let's kind of ask somebody for some help and some learning here. But to go back to your point of data, nobody's going to say that we don't need data. But what's happening at the moment is that we're using data that is like, you know, from the old system and looking at it and trying to decide on that data what to do next. Somebody like Josterblock or Connie, what they're doing is they're saying, we need a different form of system here. Let's ask some big questions about what health looks like outside the system, how we could really work, and then having asked those big questions, let's use the data available to go in that new direction. But otherwise, you're kind of like basically always looking over your shoulder and trying to kind of create something new. I mean, really, it depends, Matthew, whether you think this is a moment of paradigm change or not. Do you really think that 50 systems are going to get us through the 21st century? I mean, I just do not. And I think we can all be very nice and say that this small thing is wonderful, which is generally what I do most of my time, but I just thought I could come here and I could say that, or I could tell you what I really think.
So I think it is... It's fun, this, isn't it? I think it is a paradigm.
I'm wishing I talked a bit longer now, so I didn't have to subject myself to this, obviously.
I think you can handle it. I think it is a paradigm shift, but I think the way paradigm shifts happen is complex. It's to do with, you know, if I can recommend a fantastic thing to listen to, there's a wonderful, it's many years old now, but there's a wonderful Radio 4 series called Who Done It? And it's an examination of how it is the teenage pregnancy rate in the UK fell by about 50%. Why? And what the programme does is it says, well, maybe it was long-term contraception. Maybe it was the national teenage pregnancy strategy. Maybe it was Facebook because it became more fun to be in your room than to hang around a bus stop. Maybe it was Vicky Pollard because she made teenage pregnancy a kind of laughing stock. maybe it was the fifth thing. And the conclusion that the programme comes to was it was probably all of them together, and they all combined, and they reached a tipping point. And so that, I think paradigm shifts happen, but I think they happen through a tipping point, which involves some of the things you're talking about, but it also does involve data. And what I think,
straw man. Hi everybody, I believe in data. Just to make it clear, I mean, we're not having a conversation about that. Would be saying like, do we think it's important to read or write?
Hold on, but it sometimes. So I talk. There's lots of GPs here. I don't know a GP who doesn't want to move to a situation where they can be in the business of reaching out to their population health management, identifying people's needs, prevention, and out of a mode of reaction to overwhelming demand. Mm-hmm. This isn't a kind of moral problem. This isn't a lack of commitment. This is just, I want to get there, but it's incredibly to get to. And the story of this whole conference really has been, we kind of know how we want things to be different, but it's incredibly difficult to do now because we're in this kind of capacity squeeze.
So can I just say, I just want to, I'm sorry if anybody heard that I think that GPs don't want to get there. My experience is that GPs are desperate to do this work. It's extremely hard to do in the systems that we have. And this conversation is about how to shift those systems to make that work actually work. It's not about whether there's anything wrong with the GPs.
So I guess what I'm saying is it feels to me as though there has been real change in terms of people's understanding of what they want to do. There's been a fundamental shift in the degree to which people in the service take inequality seriously and recognise that you have to build equality into every element of what we do. So I suppose what I'm saying to you is I think there has been some change, and if we're going to understand how we achieve more change, we have to appreciate the change that has happened and to think deeply about where does the immunity to change exactly exist within the system. Now, the book is a very, very good book, and I agree with nearly everything in the book, so don't think that this conversation is anything about detracting from Hillary's core thesis. I guess what I want to get to is why is it so difficult, even when people are no longer playing the same tune as they were playing a few years ago?
Well, it's so difficult because there isn't enough resource, and resource is in the wrong place, and in a market framework, resource is not coming out of that place. Resource needs to move from the top, from profit, from big salaries at the top, down to kind of where it's needed in the community. It needs to come out of management. That is a thing of data and kind of using technology in a different way. But, again, I mean, we could talk about that. Technology is being used to kind of make existing systems more efficient. It's not being used in the way that my own work, Wellogram, in the way that Bortzorg uses it. And that is because we haven't actually got a vision, I don't think, of where we're going to go. We haven't got a news story. When we created the health service, we had a publicly owned big story, as I showed you on the building, about the importance of health and how health is created. I don't think we've got that story for this century. I know we've got lots of ministers' documents and white papers, but I don't think we've got a shared story as a nation of what health is going to be and how we're going to create it.
No, well, I certainly agree about that. I want to just end with one or two questions really quickly from the audience, partly to lift the tension on the stage.
I think it's a bit of a shame because I think, you have kind of done that sort of 1950s grilling, but we could have had a conversation about how to actually make this happen.
No, well, that is a conversation.
Right, well, maybe somebody in the audience can
There's a lady there. Do you mind shouting out? Because the mics are a long way away from you. So.
When are you going back to normal? And for me, there's two things wrong with that. One is, right, we want to go backwards. We want to move forwards. And the second thing is, what is normal? And what you described with Wellogram, with social prescriber, with well-being practitioners...
It's not social prescribing, but yeah.
Well, no, it was a list. Yeah.
With all of the new models you described, is absolutely fundamental to how we deliver health and care. Because what I do as a clinician is only the tip of the iceberg.
So the key thing is, when people want to ring up their practice and say, I can't get an appointment, I want to see the GP face to face, why aren't we having the honest conversation with our public to say, actually, seeing a GP face to face might not be what's right for you? Because in the story you described so eloquently about Kate, actually seeing a GP in a 10-minute consultation wouldn't have helped her at all. And having that longer time to talk about the issues that are really important to her, and the fact that she's a carer for her husband and her child, she has diabetes, all of that, those wider determinants of health are so crucial. But it doesn't need a clinician like me to actually address all of that. It needs a wider team.
I
and
agree.
Actually,
can I just respond, because we're almost out of time? Of
course you can.
I mean, I think the thing is that this is a cultural shift we're talking about now, and we have a culture of scarcity, and we've had a narrative of scarcity, which means we've got a public who are extremely intelligent and understand that a change is likely to be something much worse than something taken away. So this really goes to how we kind of create new systems with the public, because my experience from having kind of built new systems, which is what I really do over the last 30 years, is that, you know, so long as people think, for example, that something's going to be taken away, including politicians, they'll go to the barricades. I mean, I talk about this in my book. They'll go to the barricades and, you know, keep that hospital open even when they know it should close. If you can touch and feel and experience something really new and different, then you know what that is. And that is our work. We've got to enable people to touch and feel it, so it doesn't feel like scarcity. It feels like a new abundance of something else. And that's what we've got to do. Have we got time for one more question?
Of course we have.
Is this, because I think there's somebody here waiting who got up first.
Jackie Sumner from Voluntary Action in Arran and Chichester. So we're an infrastructure organisation of 450 different community organisations. And almost that web is the new nexus, really. That community fabric is where we need to invest and build. Because I would say 3/4 of those members are doing well-being, are doing initiatives, are testing new ideas, are supporting one another. And it's fantastic. So you need to do that. We need to do care, and we can do that with the community sector. We need to respond to care, so we need a national care service for the 21st century. And actually, we need to make people financially better off. So actually, if you sort people's finances out, if you give them some stability and you work on economics, you get a healthier community. And just, it's quite simple. It sounds simple, and how we do it is over to the rest of us. But that's the radical shift that I see. And there's been pockets of voluntary sector in this. In a year's time, I want the 50% of NatFed to be community.
And, you know, I was talking the other day to an ICP chairman who said that one of the first issues they're going to talk about, or one of the first issues they're talking about, is not anything to do with the health service directly. It's debt and cost of living and impact on debt and the impact of debt on mental health.
That's like Wellgram, isn't it? It's
yeah,
like,
and that's happening at the kind of bureaucratic manager level, is they're saying, okay, there's a growing issue that's going to drive demand. Let's think about a joint approach to that. Yeah.
Workforce which is well paid, and you will get that throughput in from those needs. You will make the community wealthier. It will be a circle.
Okay, Hilary, closing words. I don't want us to not be friends anymore.
I'm not so, you know, you can't be in the business of change and be so sort of fragile. I'm not so fragile. But I think the way you led the conversation is interesting, because I think that this is not really a moment for sort of adversarial conversations. I think it is a moment for kind of turning over stones and looking at what is working, why it's working, what is that principle there that shows us how we can construct a new system. It's really important that, like, you know, I think you giving me examples that you've seen of where stuff is working. That's what I'm saying. A lot is working, but it's at the margins. We really need to think how we move it to the centre. As the last speaker just said, it's about resource. And I suppose one of the reasons that I'm kind of so punchy today is because I think ICS, ICBs, you know, could do as Beveridge did. They could say, we are only funding this now. If you want to be paid, we are working in this direction. We're going in this direction. So let's see that happen. Let's not pretend we're in the 1990s and a kind of small innovation is the way to go in this moment of paradigm change. That's my kind of message here today, I suppose. And I hope afterwards some of you will come along to the book signing and we'll get some chats.
Donal, where's the book signing?
It's up where the food is being served.
Excellent. Lunch and books.
Brendan, once again, you're a star. So up where the food is being served, you can find the book, and Hilary will sign it for you. It's been a fascinating...
Thank you for coming.
It's been a fascinating session on all kinds of levels, hasn't it? But let's thank in particular the brilliant Hilary Cotton.
Our next session is Beyond Hospitals, How Do We Truly Transform Healthcare? Please welcome to the stage our speakers and session chair Matthew Wynne, Director of Community Health, NHS England.
Well, good afternoon, everybody. Welcome to what is going to be probably the last big chunky item of NHS Expo. And well done for making it. And thank you for coming, which I think is probably going to be the highlight of this conference. I should say that unashamedly, knowing who's sitting next to me and the content that we're going to try and cover. So during this session, we're going to get some highlights and insights from our esteemed panel, and we will be allowing time for questions. If you want to pose a question, we'll do that at the end, and you can do that in a normal way, and we can get a mic to you. But also on the Slido, I hope I've said that correctly, app and mechanism, you can post questions as we go through the session, and then we'll have a look at the major ones as we get to the end to make sure we cover what's on your mind. So, really important topic. How do we both understand how we're going to provide care? How do we understand how our population want care provided to them? And how do we understand what is the practical, what are the good options, what should we be thinking about now and in the next months and years? And that's going to be the content of what we're going to be talking about today. So let me introduce the panel. On my right-hand side, your left, Steve Parris, National Medical Director for NHS England and NHS Improvement. Jennifer Dixon, well-renowned Chief Exec of the Health Foundation. I'm Matthew Wynne. I'm Chief Exec of Cambridgeshire Community Trust and also National Director for Community Health. On my left, Juliette Bouvier, who is the Chief Exec of the Stroke Association and the Chair of the Richmond Group Charities. I think I've said that correctly. And Dan Harmon, on the left-hand side, a consultant, community consultant, geriatrician in Hull, and will explain lots of the great work they're up to in that area. So that's what we're going to kick off into. And I'm going to start by posing just some questions for our panelists to kind of give their views. What do they think? What's on their mind? So Jennifer, I'm going to start with you. You spend a lot of time in the Health Foundation thinking about trends, what people expect, researching the kind of market and also the dynamics of giving care. What's that telling you about this important area of life outside hospital and what the expectations are?
Thank you, Matthew, and good afternoon, everybody. Can you hear me? No, I didn't think so. Shall I? Oh, thank you. Can you hear me now? Oh gosh, I can hear myself. That's great. So just on some trends, I mean, I think you were all familiar with the headlines of the trends. Obviously, we're all getting older, more people, older people, the population's getting larger, more people are being diagnosed with chronic disease. And so, as we know, people start collecting them. It depends where you live, how deprived, in what communities you live, but some people start collecting chronic disease at 50. Some others start collecting them at 70. But there's more and more being diagnosed, and in fact, more are being diagnosed than faster than population growth. So we're uncovering more things. We also know that risk factors are crowding in, obesity and all that, which will lead to chronic disease, mental health in particular. We're doing quite well on smoking, so tobacco, which is the biggest killer, is declining in terms of smoking. But we also have against that austerity, we have poverty, we have the stress of precarious jobs that will weather health. So the health fabric, we think, could actually fray a bit more as people are getting older. The good news is that the chronic diseases seem to be not always associated with limitations of daily living. So although we're collecting chronic disease, we're not necessarily needing support in the home to get around and so on. Just some other very quick factors before I hand over to someone else. We all know about the funding squeeze, and I think there's a slide, or at least I'm going to show a slide now. Hello? Can you see anything? No.
Yes.
Oh, you can? Okay. So here is a graph which just shows you some aging and morbidity share of future healthcare costs. And actually what you see on this waterfall diagram, that the biggest driver of future healthcare costs that we have calculated at the Health Foundation, not necessarily population size and age, it's actually chronic disease. So how we manage that is absolutely going to be critical. We know that over time, we know that there's economic squeeze, that's likely in future, but what you may not know is over the last, few decades, health is taking an increasing share. It's now over 40% of day-to-day public sector spend. The Secretary of State mentioned that. No sign of that abating, and it's squeezing out other things we like to spend money on, education, housing, all the rest of it. So those are some trends. We're going to need more staff, we're going to need more beds if we carry on as we are, so we need to do something differently. And then the last thing is, of course, public support the NHS, no sign of that abating. There's been a nosedive recently with the British Social Attitude Survey, but also more people are feeling more confident about technology, which is good, and signs that that will continue in future. And the staff, I just point to one survey, which was an interesting survey of 2,000 clinicians across the globe recently, and it was very similar what they were saying. They expected more care in the community, more AI-based decision support, more gene sequencing, more multidisciplinary teams. So that all the types of things we're thinking of, everyone's trying it, and we'll get onto that later. Thank you.
Thanks. Thanks, Jonathan. Juliet, you represent Richmond Group Charities, really influential, do fabulous work, and we've seen some interesting reports since the pandemic from people like the Red Cross and others on the experience of receiving care and what it's like to get care from the NHS or not get care at times. What does that tell you from your perspective, and what should we be thinking about in that respect?
Yeah, thank you, Matthew. So for those of you who know me, I'm normally a cup half full person, but I'm just going to present some slightly depressing statistics about the experience of people living with multiple long-term conditions, both pre-pandemic and post-pandemic. So we're all aware of the growing older population. We know that the number of people aged 85 plus is going to double to 2.6 million over the next 25 years. We know there's going to be more people living with multiple long-term conditions. 1 in 4 people are living with 2 or more multiple long-term conditions now, and by 2035, the number of people who are going to be living with 4 or more long-term conditions is going to double. And a third of those people are going to be experiencing mental ill health. And we know that that ill health is unevenly distributed. And unfortunately, the pandemic has just exacerbated some of that variation. So we know that 28% of people in the most disadvantaged areas are living with 4 or more multiple long-term conditions, compared to 16% in the least disadvantaged areas. We know that people with multimorbidity actually develop multiple long-term conditions up to 15 years earlier in deprived areas compared to those in more affluent areas. And we also know that people with multiple long-term conditions are consuming 70% of the NHS resource. So this is quite a big long-term health and care challenge for us. The reality is that people with multiple long-term conditions pre-pandemic were telling us time and time again that their care wasn't coordinated, that they felt abandoned when they left hospital. Unfortunately, the pandemic has exacerbated that. And Age UK, one of the Richmond Group partners, has been doing a series of research. They've done 4 rounds since the start of the pandemic. Each round is with about 15 to 20,000 people, so we're talking about quite large populations. And what we saw between March and August 2020 was a really sharp deterioration in people's health, particularly loss of mobility, increased pain, increased fatigue. And there's limited evidence of recovery since the start of the pandemic. And there are some really quite sharp data about the people who are having the biggest, for whom it's having the biggest impacts, and that is carers, people living in least advantaged communities, and people with multiple long-term conditions. And interestingly, people are telling us that actually it's the disruption to their daily lives that's been a problem, but also the loss of some of the community services that they were previously reliant on. So the collapse during the pandemic of things like social clubs, exercise groups, places where people were actually making social connections. And I think that's been really hard for people. And now those people who are struggling even more with their health and care needs are now being hit by the cost of living. So it is slightly depressing, but I'm going to go on later to talk about, actually, we know a lot about how to support people with multiple long-term conditions. We know what good looks like. There are masses of resources and exemplars out there. So this is a problem that we can solve with the right leadership and the right resolve.
Thanks, Juliet. And yeah, some really serious, chunky issues that we would need to take into consideration, because it's not classic NHS care, is it? It's not the things that bind the NHS together. It's things that we are interdependent upon. And kind of just to then go into the next section and start with you, Juliet, what are you therefore seeing as some of the changes that you as the Richmond Group are seeing across the country that you think is now making a difference?
Yeah, well, I mean, as I said earlier, I mean, we know what good looks like and how to deliver it. I mean, interestingly, the Richmond Group of Charities was formed 10 years ago. And the first report that we published set out what good looks like. And that's everything that I've heard over the last 2 days at this conference. We need early diagnosis. We need coordinated and seamless care. We need services to be wrapped around the individual and to take account of their whole lives, not just their clinical needs. We need multidisciplinary working that extends beyond health boundaries into social care and the voluntary sector. We need to address health inequalities. So we know what good looks like. And one of the documents that I just want to refer to is a publication from the Richmond Group. It's on the Richmond Group of Charities website, and it's called the Multiple Conditions Guidebook. And what we've done over the last 4 years is we've done some really in-depth ethnographic research with real people in real places living with multiple long-term conditions. We've been hearing their stories about what they're telling us. And from that, we have also captured from all the kind of partners working in the system on the challenge of multimorbidities, some really great exemplars, and all of that is now written up in the Multiple Conditions Guidebook. And I just want to very briefly talk through the sort of 8 principles that we know need to be taken into account in the design of services for people with multiple long-term conditions, because if we can get these 8 things right, then we'll make a real difference to people's experience. So the first is around involving patients and carers in a meaningful way and truly co-producing the design, delivery and evaluation of services with real people and communities. The second is the importance of taking the long-term view. It is tempting just to fix problems in the short term, but not to actually kind of focus on people's kind of long-term aspirations and needs. The third is to look at people's whole lives. So that's recognizing that people are way more than their clinical conditions, that it really is important to find out what matters to people, what are the goals that are meaningful to them in terms of living fulfilled lives, and the importance of taking into account not just social networks, but also things like housing, finances, all those other social determinants of health that I'm not sure within the NHS we're always that good at thinking about. The fourth is being rooted in place. There have been so many conversations over the last 2 days about place-based care. The fifth is around all for one. You know, let's work in partnership. Let's really make best use of all the assets that sit in the community, including with people and communities, and foster collaboration. The sixth is around the importance of care coordination. The health and care system is incredibly difficult to navigate, and patients become expert by experience, but when they develop another long-term condition, guess what? They have a cancer diagnosis that they've never previously had a cancer diagnosis before. They start all over again. So I think care coordination is really important. Seventh one is time to talk, just the importance of both peer support, connecting people with other people, going through the same experiences, but also us as health and social care professionals making time to talk. Because so often when people feel listened to and information, complex information is properly explained, they are able to self-manage, they want to be able to self-manage. And the final, and possibly the most important one, is what we've called Minds Matter, which is about recognising the importance of mental health and mood. So I think if we could all adopt those 8 principles, we would go some way to tackling the challenge, to be honest, of long-term multiple conditions. And I think the final thing that I'd say just on this point is to remember that no one size fits all. I mean, we're all individuals. We all have different personal circumstances and clinical needs, and I think it's really important in the design and delivery of services that we do flex and adapt to people's individual circumstances. I mean, if somebody's carer dies, for example, then that, kind of massive support network has just been stripped away, and suddenly that person can go from quite an expert patient to suddenly, again, feeling very fragile, very vulnerable. So I suppose we just need to recognise that, and we talk a lot about care in people's own homes, which is absolutely right, but we need to remember not everybody has a home that is safe, secure, comfortable, and people may well be experiencing financial insecurity, energy insecurity, food insecurity, all those other kind of facets of life that we really need to take into account when we're designing and delivering services.
Thank you. So, Jennifer, I'm going to come to you before we bring a clinical view from Dan, but what do the studies tell us about the people's perception of care being delivered in a different way? So things like virtual wards and other things. What are you seeing from your kind of viewpoint?
Thank you. Well, on the COVID studies, for example, the out-of-hospital, on the out-of-hospital care, the virtual wards that have taken place with COVID, people are generally positive, particularly younger people, particularly people under 50, people more tech-savvy, older people, people who don't have English as a first language, are finding it more difficult. So I think there's a cohort effect here. As we go through time, there will be more and more people who are accepting and interested in technology to help. In terms of the evidence on the impact of virtual wards, for example, it's very mixed. We don't know yet. And it's partly mixed because the virtual wards that have existed have had multiple things going on. There's complex dynamic change in these things. The intensity of delivery is different. The type of things delivered, despite guidance, is different. The patients are different. The amount of data you can collect is different. So we're muddling along in the fog at the moment when it comes to virtual wards. There are some good evidence from some studies, but other studies are showing no impact. And in particular, the COVID oximetry managing at home shows very little impact on readmissions, on early discharge, and on use of A&E. So I think it's the right thing to do, but we have to be humble and think about its management, how it is managed, how it is collected. And sorry, last thing, big message for the future. If we really think that we have to do a lot more out of hospital, which I think we all do agree, and with the community, we have to have ways of assessing the impacts far better than we have at the moment. As I say, it's very foggy, and that's not helping anyone. Thank you.
Very foggy. It's one of the more politer terms I've heard for that to be described, Jennifer. Dan, I'm going to bring you in. So we've heard from Juliet and Jennifer about inclusion. We've heard about the impact of COVID on hitting people from deprived areas. You live and breathe and work in an area that is very deprived, at the coalface of all this, so to speak. What's your experience of how to create that inclusive approach, especially where homes aren't great at times, I'm sure, as Juliet described? What are you seeing in terms of that care delivery?
I think that involving patients, the public, in the decisions we make around service redesign is really important. So we, myself and colleagues that are here, work at a place called the Jean Bishop Centre, which is an integrated care centre over in a very socioeconomic deprived area of Hull. And the public were very important in helping us set this centre up. And we deliver anticipatory care to the whole of Hull and East Riding, using population health management, using electronic frailty index and practice intelligence to refer patients into our service that are at risk of frailty so they can have that comprehensive geriatric assessment, that multidisciplinary team assessment. But the assessment is based upon what the person wishes to discuss. We've designed something called a patient concerns inventory. So moving away from the traditional primary care referral to secondary care with a, please could you see this patient with unintentional weight loss, we focus on a questionnaire that has been designed by patient groups to tell us what people wish to discuss with us when they see a multidisciplinary team. And it's that patient focus that I think is really important in trying to address the 8 steps that we just discussed as well, which is to put the patient at the centre of the agenda, respond to their issues that are not just physical health related, but some of it is socioeconomic, and loneliness is such an important issue at the moment. Creating space in that model to have an advanced care planning discussion in a proactive manner. I think in terms of patient experience and patient views on hospital care at the moment, I think fear is a very worrying factor that has creeped into patients' decisions around hospital admission. I, on a daily basis, have conversations with patients, and when they lack capacity, their next of kin, around hospital care and escalation of care to hospital. And it's the fear of going in that ultimately many patients tell me now they'd rather stay at home and die than be admitted to hospital. And some patients say they'll only go there as a last resort, which puts a huge amount of strain on clinical teams in the community in terms of risk-taking, and when is that point at which you would escalate care. So I think the opportunity to have planned, proactive, anticipatory care discussions with patients is really important, and we need to create the space and time to do that. And I think that in Hull we are not unique in that we have specialist services that can facilitate those kind of discussions, but that anticipatory care is only part of the jigsaw, and linking that to the reactive care around the urgent community response when patients reach crisis, and getting them out of crisis and then offering anticipatory care is equally important. And that's where I see the advent of things like virtual wards as being uniquely beneficial to a patient cohort that is frail, that we can treat the crisis, manage patients for a defined period of time in their preferred place of care, and then offer an anticipatory care response. So if we can unite all that, that would be lovely.
So just for this last section for panel members' views, we're going to focus on, well, what next? So we've heard a diagnosis, we've heard the stark reality of what our local communities actually receive or what they don't receive, how things have been impacted. Dan set down the challenge of all those things, if we can set ourselves to get all those things sorted. So let's just focus, and I'll start with you, Steve, from your national role. There's a lot of complexity in there. And within there we have lots of, and Claire Fuller's stock take recently talked about the need to be really clear on planned care, segmenting our work according to kind of potentially, simplistically put, older people that kind of will probably need a lot more care rather than a younger age group, tech savvy, as Jennifer said, that can get episodic care. What are you looking at and leading forward in terms of that kind of urgent care world, getting the balance right with how things are going to happen, and actually some of the things that people will look forward to actually say that's going to give us some solutions? Not setting you up for much there, but what's in the boiling pot?
Well, thanks, Matthew. And let's look at it through the lens of urgent and emergency care. And of course, it's so much more than urgent and emergency care, but clearly that's an important part of the services that we provide. And of course, it's a set of services that, as we all know in the room, and as we heard from Amanda and the Secretary of State yesterday, is under extreme pressure at the moment. And we will be undertaking a strategic review of urgent and emergency care over the course of the next few months into the autumn. And the reason for doing that is to take a longer look, more than just this winter, beyond this winter and beyond the next winter, at the sort of pathways of care, the sort of systems we need in place for the next decade. First thing to say is demand is important, and you've heard the story on demand. You all know this. We are thankfully living longer, but with living longer comes more long-term conditions, more multiple conditions, and the population growing too. So we can see that demand. We saw it pre-pandemic. And I'm sure it will continue. Now, I think it's important to say that there are things that can be done to influence that demand, and there's a wide range of things. Jennifer talked about some of them: obesity, smoking. Yes, we are doing well on smoking, but we could do an awful lot better. And I think the Khan review on smoking making smoking obsolete that was published 2 weeks ago, I think lays a track to that. So it's important for us to remember that there is a lot that can be done to reduce that demand. In respiratory disease, if we diagnose people with chronic obstructive airways disease earlier, then they may not be diagnosed on their first admission to A&E with an exacerbation. So lots to be done on the demand side. But on the supply side, we tend to think of the supply of the urgent emergency care pathway in a number of different channels. So the first Matthew's talked about, which is primary care, and I'll come back to that in a minute. Then we've got the 111 service, which has evolved over time and may need to evolve again. We have the 999 service and the ambulance service. We've got urgent treatment centres. We've got emergency departments. And we've got a host of other hot clinics. We've got same-day emergency care services, direct access services. So it's a full range of services. And I think what we need to do firstly is to look at all of those and see what the future looks like. So I think you're quite right, Matthew. Claire has set out in her stocktake the sort of beginnings of what urgent and emergency care might look like in the future in primary care. And so I think the questions to be addressed there are how the 111 service better supports primary care, how it's more integrated into primary care. I think there's a question over urgent treatment centres. Their alignment can be ED facing, they can be more community and primary care facing, and both might be right models, but the context may require different models in different parts of the country or in different systems. But I think the first thing I would say is that we need to think about how primary care, urgent and emergency care, and its provision in new neighbourhood teams and primary care networks, 111 and urgent treatment centres fit together. On the ambulance service, clearly the ambulance services are facing a huge amount of pressure at the moment. And I think when that happens, you start to see the stress points. And so I think coming out of the pandemic, we do need to look at some of the aspects of how our ambulance services are delivered and what has worked well during the pandemic, what's not worked so well, and what we might want to do to fix that. That might be around skill mix, it might be about first responders. There's a whole host of things in ambulance services. Urgent treatment centres I've talked about a bit. Where should they be? What staffing model, hours of opening, how they support primary care, and how they take some of the pressure off emergency departments, which increasingly, in my view, need to be the departments. I'm calling them emergency departments rather than A&Es, where the sickest patients are managed, the ones who need the most high intensity and specialist input. And of course, same-day emergency care is something we were developing prior to the pandemic. We need to do more of that so that people, if they do need to go into a hospital setting, can avoid admission if we have the appropriate teams in place and the appropriate diagnostics and the appropriate pathways in place. So I think all of that needs to be under review. Final point I'd make is I've kind of put it into the supply channels, but of course the trick is how you join all of that up. And I think you heard from Dan, I visited the Jean Bishop Integrated Care Centre. We were trying to think when it was actually. It was either 2018 or 2019, around the time it opened. And I was hugely impressed with the work they were doing in Hull and the anticipatory care, identifying their frailest patients, working in the winter to ensure that they had the support that meant that they were less likely to have to be admitted into hospital. And clearly that is something that we need to do more of, and it's clearly something that is core business for integrated care systems and integrated care boards, understanding the population health, who are the sickest and frailest in the population, and how you support them the best. But it's also about taking that holistic view of that whole pathway and understanding where the risk is sitting. The risk can be sitting on the ward. It can be sitting in a ward where staff are feeling pressure because the number of nurses for the number of patients isn't quite ideal. That can then lead to problems with patients being admitted from the A&E department. So then there's crowding in A&E, and if that's not happening, there may be ambulances sitting in the forecourt waiting to offload patients into the A&E department, and if there are ambulances sitting on the forecourt, they're ambulances and crews that are not on the road, and that is why the response times of the ambulance services are not where they need to be at the moment. And as Amanda said yesterday, there is a clear line of sight from one to the other. And I think in managing the urgent and emergency care pathways, local systems having a clear holistic view of the entire pathway, where the interventions need to be made at any particular time, how the staff need to be supported through that entire pathway at any particular time, is the third bit of managing these pathways. So demand is important, understanding what we can do to influence demand, a review of all the supply channels, the sort of integrated anticipatory work that we've heard that avoids admission, virtual wards part of that, and then a clear view of the whole pathway and the levers that need to be pulled and the interventions that might need to be made and the support given at any particular time.
Thanks, Steve. We've got 4 questions on Slido, folks, so if you want to do more, please put them on Slido, or after a few more comments, I'm going to come to you as the audience, so get those ready. Dan, back to you before I get final comments from the other panel members. You've moved out from being an acute hospital geriatrician. You're now in your fabulous centre in Hull in a multidisciplinary team. What's the practical ways, therefore, that Steve's just put lots of those challenges into perspective, but what are the practical things that you are doing day by day with your multidisciplinary team, because I'm sure it's not all about you, but I'm sure it's lots about you, that actually make a difference to provide that glue that you've been talking about?
Thank you. You're right, it's not just me, and there are a couple of other team members here, but I think it started with a few geriatricians working closely with the CCGs as they currently still are and were then, and the multiple providers across our system to say that we needed to deliver something different to support patients and prevent crisis management, which is episodic and has extremely poor satisfaction when we do it that way. So it has grown, it's grown significantly, but the most important part of that is, as I've said already, the patient engagement in the process to make sure we're getting the care right. And to go back to an earlier point around evaluation, you know, getting some independent evaluation of patient-reported outcome measures is so important, as well as looking at the system data around ED attends, hospital admissions and unscheduled primary care usage. So we've worked collaboratively with our partners at University of Hull. We're due to publish this year a non-randomised control trial looking at PROMs in relation to anticipatory care, which I think is unique. So we'll be happy to share that as that's published. But that data takes time. You know, you need to look back 24 months and ahead 12 months after a comprehensive geriatric assessment to identify if this is working.
So Dan, can I just push you for a second?
Yeah.
And one of the questions on Slido is, how do we get resource to move to actually meet demand? And part of that is you've just kind of quickly said we got together and we kind of got ourselves sorted out, so we provided that care wrapped around at home. That is pretty unusual. It's not a normal approach where there's a functioning multidisciplinary team clinically supported. So how on earth did you pull it off?
It's bumpy. So I don't believe that moving provider organisations to deliver the care that you want is the right way forwards. We should be allowing staff to work across organisational boundaries to deliver the right care. And what we've seen through our model is we now have respiratory physicians working with primary care colleagues, again around frail patients. We have diabetologists and movement disorder services that have moved into the Jean Bishop Integrated Care Centre. And these are colleagues that are not intent on leaving the acute trust and going to work in the community. They would like to have their feet, I don't want to say in both camps, but you get my point. We need hospitals without walls. Myself and Dr. Falwell, Anna Falwell, who's here, we decided to move to work for the community service provider because there was so much that needed to be done around anticipatory care. But we still work in an acute trust delivering our own calls. We're just employed by somebody else now. So it's not one size fits all, but we have staff that work on rotational basis, from an allied health professional, physios, OTs, meds management teams that are employed by our acute trust that come and spend time with us. We've got 5 whole-time GP equivalents in our team now when we started with 2, but that's 12 GPs, 11 of whom are still working in primary care and doing a day a week or 2 days a week in our team, which helps upskill the staff within their primary care settings as well. And again, we're not bleeding primary care to deliver this important piece of work. But satisfaction is much higher among staff because we can see the benefits for the patients. And that was one of the drivers for me coming out of hospital and doing this. I knew this worked, I could see it, and I could see it. but we were tied to delivering ward-based care, and I believe geriatricians should be in the community in reaching into hospital and not the other way around as we move forwards, because that's where our skill set lies. So allowing a workforce to be mobile and having really strong leadership within the CCG and soon to be the ICS that are listening to clinicians and dedicated clinical leadership time for clinicians to work with commissioners and strategic leads. So we had a unique opportunity that existed in Hull, I think because as clinicians we were valued, listened to, respected and challenged by our CCG colleagues.
Great, thank you. I'm sure Steve, as an ex-medical director of a big acute trust, would kind of have a view that someone reaching in perhaps is sometimes problematic for rotas and everything else. But I think you'd probably say from national medical director role, that fusion of adaptable clinical work is exactly what we need, isn't it?
Yes, and indeed there are variants on this model. We had a variant on this model at the Royal Free. I don't think it was quite in the place that Hull was, but I'm very aware that as ever there are, this is not entirely unique, and there are variants everywhere. But I think the what do you need? Well, one, you need to know who your frailest patients are. And that's work predominantly done with primary care, but with secondary care too. So that's the first step one. Step two, I think, is then creating the teams and the multidisciplinary team. You have done it in a centre. I suspect there are other models in the way you could do it as well. But I mean, the Jean Bishop Centre is a centre, but it's fundamentally a multidisciplinary team rather than the building. And then it's that coordinated approach between secondary care and primary care and social care to ensure that you are delivering the assessment of the frailest patients and then the interventions at the appropriate time to minimise the risk that they will require an acute admission. And of course, I know there was a frailty service in the A&E department in Hull when I was there, and so that was another bit for me of the jigsaw, because patients, if they did need admitted, were going to direct to a frailty unit, where again, you weren't starting from scratch because these were patients that you knew.
Thanks. And Julia, then what do you think is the key role for the voluntary sector in that kind of approach that we've been hearing from Dan and others?
Yeah, so, my microphone, sorry, I'm sitting on it. The voluntary sector does have kind of long-term relationships with, millions, frankly, of people with long-term conditions. I mean, just in the Richmond group of health charities, which is 12 charities, we reach over 13 million people with long-term conditions. And I think what's special is that, we're with them for the long term, so we really understand their lives intimately. And we provide a lot of support for people to be involved and to have their voice in the design and planning of services. So facilitating that community engagement and that community voice is a really key part of what we do. But we also spend millions of pounds on research, training, volunteering. Between us, we employ thousands of kind of care coordinators who are really modelling personalised care. And I've been just really encouraged over the last couple of days about, there feels like a real shift in the number of services that are now valuing the contribution of the voluntary sector. And, we've also got to work differently too. I think one of the criticisms of the charity sector has been we've been rather impenetrable because we're slightly messy and amorphous, and there's hundreds and thousands of us. And so, one of the reasons why the Richmond Group works as a coalition is because we do want to speak with one voice on long-term conditions. And when we collaborate amongst ourselves, we can have real impact. So we've got a multi-year, frankly, multi-million pound partnership with Sport England that's all been about addressing pain and encouraging people to get physically active. And the data on the number of people with long-term conditions who are not only now physically active, but are also sustaining that behavioural change is phenomenal. So when we can kind of work together in coalitions and collaboratives, it's brilliant. And I suppose my plea to the audience is to, involve us as equal partners. When we are involved as equal partners right from the beginning, and we're fully valued, it's brilliant. And, you know, I would say this to Steve because he's the SRO for the stroke programme, but actually it's lovely. It's a really nice example of the Stroke Association as a voluntary sector partner being truly involved equally in all the conversations, and we've got a shared vision. But it's not always like that, and we often get invited to NHS meetings at the last minute because suddenly somebody thinks, oh sugar, we'd better have a patient voice at the table. It's real tokenism. It's really frustrating. We often take the long view. Sometimes we can be annoying because we can be a critical friend. We can say things that the system doesn't always want to hear. And I'm not sure that the system always quite knows how to deal with us when we take that different perspective. And we are still very fragile in terms of funding. I mean, even at the Stroke Association, 70% of our contracts with health and local authorities are 12 months or less in duration, and we have to go through this annual tendering round. A lot of charities have collapsed as a result of the pandemic. Please, if you see us as equal partners, invest in us so that we can be a sustainable partner and solution, because at the moment, short-term contracting is not the way forward, and it's just contributing to the fragility of the voluntary sector.
I think that's a really good point for us all, that we rely on the voluntary sector. I was down in Cornwall a month ago when I was in their West team, and the voluntary sector coordinator for the West Cornwall was based in the community nursing therapy team, and she was just fabulous at actually working with people once they were coming to the end of their rehab to understand how all the community assets, and we use that word, but it really was the community assets, could support that person rather than them landing with a care package. The one thing that made a big difference down there was the ongoing funding for her and her networks of people, and she was saving money hand over fist in taking people out of formal care into different approaches. And we'll come back to this, I'm sure, in questions, but last point, Jennifer, you do fabulous work looking far and wide. What can we learn internationally? What would your major kind of plea be that we would take into consideration when we're designing things going forward?
Yeah, just a couple of, can you hear me? Yeah. Just a couple of stand-back comments on practicalities first. One is, if you look back over the last 20 years, the lion's share of growth of spending in the NHS has gone into the acute hospital sector, practically nothing into the other side, with the exception recently with some more money for primary care, but not that much. So if we're really serious about this, we have to practically change that in a big scale. How we do that when there's huge pressure on electives is another matter, but that is what's we need, and capital funding to match, and to trial purposefully technologies that can be labour saving in the out-of-hospital space. That's practical. Second thing is, what are we going to do to turbocharge the alignment that Steve mentioned, so that lots of fragmented teams doing great work can work together across a pathway? Now, one philosophy is let 1,000 flowers bloom, nudge people towards some kind of model that seems to be working. Another is to say we don't have time for that. We have to somehow turbocharge by having big, bolder, big bet demonstration sites, initiatives to try to learn faster. So that's another sort of policy question on the table. And I'm not sure 1,000 flowers blooming as it is at the moment is fast enough, actually. And then the third thing is, going back to your question internationally, actually, to be honest, I don't think we have masses to learn internationally. I think everyone is trying the same things. There's been a recent review by WHO, a recent review by OECD, a recent review by the European Observatory. Everyone's trying the same kind of things that we are. I think upskilling, particularly in the community with nurses and pharmacists, is got a huge amount of support. People are trialing technological change. But to be honest, and quite frankly, they don't have the assets we have, particularly with respect to the one system and with respect to the data spine that is going to connect everybody and help to evaluate and test new changes. So I think those are some of the challenges we've got ahead, thinking and standing back from a national policy perspective.
Thanks, really helpful. So, dear audience, it's time for questions from you. We have a roving mic, but we also have 4 stands. If you can get to a stand, I could bring you in. So if you can't get to a stand, can you have a wave and we'll get a microphone to you? Whilst you are thinking, and I'm trying to look around to see where those hands are coming from, there's a couple of questions on Slido I just want to maybe pose to the panel. So, Dan, can I pose this one to you? Staff are burnt out and leaving. We won't finish there. Apart from pay rises, how can we think creatively about retaining our workforce? Because I think you touched a little bit on that earlier about how you could do that.
And it's a really good question to which I don't have a congruent answer, but what I would say is that I probably felt just like that, and that was pre-pandemic. But I think the ability to see that you're making a difference in the care that you're delivering, and that you can start to accelerate that and make that plan and that model of care bigger, it changed my motivation and improved my job satisfaction at work. And it's not to say that we don't work long hours in our team, but when you can see that you're making a big difference, and actually that people are listening and we're expanding that care across a wider footprint, I think that's kept myself, Anna, and other colleagues going. But I do go back to the point around allowing people to work across traditional organisational boundaries. And so, actually, I didn't really understand, I probably still don't, I haven't had any primary care training. My primary care doctor colleagues who trained us on the GP VTS programme spend years in the hospital learning about hospital medicine. Our specialist trainees in the hospital setting do very little in primary care. So I know that's changing, but I'm not surprised there's a discord between understanding what's happening in the community and what happens in a hospital. So it's been really fulfilling for me as a community geriatrician since 10 years now to spend half my time in the community and now almost full time in the community. So I think we all think we're busier than everybody else, and actually we're all really busy and stressed, but working together in this way across boundaries is helping. I don't think that answers the question about how do you retain staff, but certainly more fulfilling.
And a good team always. And I mean, one perspective from my own organisation, Cambridge Community Trust, is that we also have to focus on what's impacting them now. And community staff are especially impacted by the cost of fuel, and massively so at the moment. Community nurses, health visitors, etc. So, we've taken out the cap so people don't fall down to a lower rate. We will continue that way through. We've negotiated higher lease car arrangements. We've got a hardship fund for staff. All of that's from normal revenue. So please don't get your finance directors saying this is daft. Well, if you don't do it, you'll lose staff anyway, and you'll be in a worse position. So I think we need to do every single little bit possible, because all of that makes a difference to our jobbing staff who are already doing a tough thing. Right, I'm going to go to number 2.
Hello, can you hear me okay?
We can.
Yes, really good talk. I'm Director of Nursing for Professional and System Development in the South East, NHS England, and I lead on the community portfolio, so really good to hear your talk. It's around the funding and resources. We deliver quite a massive community portfolio, from integrated care to care closer to home, having a strategic plan and priorities, lots and lots of things, but actually we deliver it using matrix working, and we've brought a team together, but actually none of it is funded, and just really thinking about how we can have it funded so that we can sustain a program.
Just an easy one. Steve, should you and I attempt to have a go at this one? What's your...
Why don't you go first?
Do I go first? That was adeptly put. So I think it's interesting. I've had quite a few conversations today with people about this point of how do you ensure that when people are doing great work, that where the benefits, and you're talking particularly about financial benefits there, accrue and therefore get reinvested back in the areas where actually people are taking risk and undertaking different things. And we all see, and we all, it's a very trite thing to say, integrated care boards will solve this. Well, they will and they won't. So I think they will if they are able to work with their providers to share their financial, clinical, staff risk together. And that is the heart of collaboration. It's very hard to do. We've been commissioned in our silos up to now. But I'll just give you an example of one area in my organisation, in one ICS we're working. We're looking to go into a 3-way arrangement with the mental health provider and the acute provider. And essentially that will mean that where those things, where admissions plateau or they go down or we're spending less here, actually then the money gets recycled between us all to see where actually we're making the investments to make that benefit happen. I can only see that's the way to happen and make it real, because for a long time we've tried to commission in silos, and then we've asked clinical commissioning groups to be the kind of broker between everybody, and that's an incredibly tough job. We need providers and integrated care boards to do those things together and take responsibility for exactly what you're saying, is we only have a finite amount of money, how do we divide it to the best approach? Steve, what else?
Well, I think, I mean, I obviously don't know the exact circumstances, but I think this issue of the cost occurring in one organisation and the benefit accruing somewhere else should be something that integrated care systems and integrated care boards should reduce. So I think a mark of success would be we see less of that, and we see the ability for money to move around, and for people not to be afraid of incurring a cost if the benefit is going to occur in another part of the system that either they don't have the same accountability for or the same financial accountability for. It's difficult to eliminate completely, and of course there's a separate discussion around where the benefit occurs in social care or the benefit occurs in employment. But nevertheless, I think a good North Star is always to do the right thing, and mostly people know what the right thing is.
Yeah.
So really good feedback, and I know most of the funding, what you're saying, will come through the providers and the ICSs. But I'm really thinking about some regional funding similar to what we do for CYP, LDA, the UEC, and virtual wards, which is really working well. And maybe when it comes to business planning, we could put something good together for community, because actually we want to put a business case forward just to have that funding for the region for that system oversight to support the ICSs. So I suppose just to keep that in the back of your mind.
Thank you.
That's a direct ask for money.
I think it was an ask that I'm sure I can get my national team to support to see what you're up to, and you can see that being pushed for. No, we will do that. Thank you. Really, really helpful. Juliet, just an observation from your perspective.
Yeah, just one observation. I'm really sympathetic to the community services funding challenge, and I do think the resource needs to shift from acute to community. We've been saying that for a long time. I would, however, say that actually if you can collaborate across organisational boundaries, it is remarkable what can be achieved within existing funding constraints. So if I take an example in Lincolnshire, the Stroke Recovery Service has just won the National Allied Health Professional Officers Award for Innovation and System Design. And the reason for that is it's pan-county, it involves everyone, the acute trust, the district nursing team, the social services team, the voluntary sector. The service was designed with patients right from the very beginning, so that activity was going on the things that matter to people, not activity going on stuff that just doesn't make a difference. Yeah. And the evaluation of it is absolutely phenomenal. The patients are just saying they're just getting such personalised, holistic care. And the only additional, there was no complicated governance around it. It just required strong leadership, a single dedicated SRO, and a program manager. That there was funding for a program manager to convene it and coordinate it. But it was basically a self-directing team who just knew what the right thing to do was, and they did it off their own back with patients. So I think quite a lot can be achieved within existing funding constraints if actually those organisational silos are broken down and money is pooled.
Yeah. Thank you. We have time for one more question. Number 2.
Quickly, so I was very interested on Stephen's comments with regards to sort of breaking down some barriers between 111 and UTC to try and work closer with primary care to prevent people getting to A&E. If you speak to a lot of our GPs, their duty days, which is where they're just seeing every urgent possible patient, they're seeing over 110 patients a day in one practice, one GP. How are we going to support primary care to do more to protect others when they are already themselves at breaking point? So I'd be interested in your modelling in terms of what 111 is going to actually do to support primary care. Are they going to be almost like a triage for primary care, the same ways that we're trying to promote with community pharmacies. And how are we going to promote that? I mean, if we roll back 30, 35 years when we started doing the police started doing the seatbelt campaign, and it took a full generation to really have an impact, are we going to see the NHS doing more national advertising themselves in promoting some of the changes that we're trying to land, which may be a generational thing that, you know, that in reality, but we need to land today in order to try and actually sustain healthcare services for the future?
Steve, you can take
yeah,
that briefly.
there's a lot in that question, isn't there?
Should we just focus on the first bit about primary care?
Yeah, yes, and of course, the purpose of doing a review is to come up with some of the answers, but I think in the range of answers, I think the sort of suggestion you've made around doing some of the triage is certainly one of the things that we should look at. As practices form into primary care networks and neighbourhood teams, I think how we can best use that coalition and critical mass with 111, with urgent treatment centres I've mentioned, to take some of that load actually off general practice, because of course what general practice hasn't always done very well is managing those long-term conditions. You know those patients with long-term conditions the best. You manage them very, very well. So I don't think that's the only solution, but I think it's one of a range of things that we need to look at. And then on the comms, yes, some of this is cultural and behavioural change. I'm sure Jennifer could talk to this. It doesn't occur overnight, but there are ways, I think, that you can direct people. If you can direct people appropriately, and then that direction leads to something positive, that something gets done, then I think over time people will make that change. So we know that people sometimes come to emergency departments and urgent treatment centres because they find it difficult to see their GP. We know that sometimes 111 services might direct people in a certain direction. We know that 111 services, if there was a directory of services that was a bit different or a little bit bigger, they would be able to direct somebody to a more appropriate service. So I think there's lots that can be done in this space, but I think the key sort of strategic thinking is aligning 111 to extent urgent treatment centres and primary care, urgent care into one sort of set of thoughts. And we will see what the answers are.
Thank you, Steve. Folks, we are there or thereabouts in time. We've...
Go on. Yeah.
Just 2 seconds.
So I think lots of people in here know that we have national drama programs like Holby City, things like that. Can we not get some of our actual real-life other experiences moved into some of those programs and talk to some of the story writers? Because a lot of people watch that stuff and think everything they see is real.
Good point.
So I don't think that's...
Steve Powis
I
on
have
television.
I have been tempted.
Prime
I have
time.
been tempted.
You've heard it first. I think he's going to agree. I think the whole point about education and supporting people to make good choices is a really big topic, and we could go on for hours on that particular aspect. I wanted to say thank you to the panel. You've heard some really great views and experiences from all of our members, from Dan, Jennifer and Steve. Can I recommend and commend you to go to the Health Foundation, to go to the Richmond Group website, but also to look at what Dan's doing in Hull, but also get engaged with Steve's work, not just Steve's work, Steve's team's work on UEC, because your views to shape those, shape the ideas and the way that we can do things differently in the future is absolutely important, and it will be all the more better for people getting involved. And folks, thank you for coming and for your questions, and we hope you have a great journey home wherever you're going to. Please give a round of applause for our panel.
I'm going to say a few words and then let you get off, right? Because everybody else has, so why not you? You know? So I want to say thank you, basically for staying the course, for being here right to the bitter end. It's been a great 2 days. I think generally everybody's saying it's been a great 2 days. It's been debate, it's been discussion, catching up. That's the whole point, yeah? Deepening some of those relationships, catching up with friends and colleagues. The atmosphere has been really wonderful. I think it's been a really positive 2 days. And what you've put into these last 2 days has made all that possible. So I'm glad you've stayed around because I want to thank you. I want to thank Team Confed and Team NHS England for putting this